some interesting lectures and discussions regarding various aspects of oral wound healing. And we hope we will continue with these informative sessions for the upcoming 2 days, including today also. So the chair of this session would be Professor Farooq Faraz. Farooq Faraz is working as a professor in Department of Periodontics at Maulana Azad Institute of Dental Sciences in New Delhi, and he has an experience of over 23 years in this field, and he has published around 45 papers and has special research interest in extraction socket preservation techniques. So the first lecture for today's session will be about healing of extraction socket and socket augmentation procedures. So without further ado, I will invite Professor LARJAVA to continue with his lecture. We will take the question answers at the end of the discussion. So in the meantime, if participants want to ask any questions, they can write down their questions and put it in the chat box. So Professor LARJAVA.
Thank you. Can you hear me?
Yes, you are audible.
I have some difficulties with my camera, so it doesn't show my face, but hope you can hear me. I may need to restart my computer if you want to see my face, because it's not wanting to do that. Let me try to do one thing here with the background and effects and see whether I can
Okay,
actually.
you please take your time. We'll just wait for a few more minutes. In the meantime, I request the participants who are not involved in the discussions or not speaking at the moment, please mute their mics and switch off their videos, please.
Let me just get out of here and come back 1 second. Right. Is anybody there?
Yes, we are here.
So I have difficulties with my camera, and otherwise I have to shut down my computer. But why don't we proceed with the first presentation if you can hear me? And I will try to get the video camera after the first lecture. So
if
we can
it
have a
is, because in GIAN it wants that speaker's video also. The specification this they have sent is that they want the slide as well as the video.
so I'm all right. So all right, I will re
Yeah, that's
start
really fine. Uh,
and hope that everything will be better. Thank you.
thank you.
So while Professor LARJAVA is adjusting with his computer, so I'll initiate a little bit of discussion over here regarding this topic of his lecture. So we extraction of we as a specialist and as well as general dentists, all of us come across in our day-to-day practice patients who undergo extractions. So the management of these extraction sockets has a long-term significant impact as far as functional rehabilitation of these patients are concerned, as well as it as in anterior regions, it has an impact on the aesthetic outcome as well. So we are really looking forward to gain further insights into these aspects of this healing of the extraction sites. And our chair also, he has enormous experience regarding this ridge augmentation and socket preservation techniques. He has secured various grants from government bodies. So that is also one of the purpose of including him as the chair in this lecture. So I'm hopeful we all will learn a lot from Professor LARJAVA and the discussion that will follow.
Yeah, thank you. This is Dr. Farooq Faraz from Maulana Azad Institute of Dental Sciences. I don't know if I'm audible.
Yes, you are.
Yes,
Thank you for
yes, you're
joining.
audible and welcome.
Thank you for having me in. And I think it's a wonderful opportunity to be with you all and specifically listen to Dr. LARJAVA on this aspect. As our doctor has explained that, yeah, we are also uh, trying to do our bit actually in setting up a small tissue bank at Maulana Azad, and we've been trying to you know process and manufacture different types of graft like allograft, decalcified freeze-dried allograft, alloplast, xenografts, and pericardium, chorion amniotic membrane, because specifically in perio and generally across all most of the branches, there's a huge need of biomimetics and tissue engineering products as such. So I think it'll be a quite a fruitful session. Listen to Dr. LARJAVA on his take on these things and what are the latest in the field of biomimetics and tissue engineering.
All right. Can you hear me and you can see me now, right?
Yes, we
Oh, yes,
can.
sir, we can.
All right. So thank you, everybody. Sorry about the delay. Sometimes this Zoom is a little tricky and the camera doesn't want to engage. So thank you, everybody, coming back to this wonderful GIAN course. And today we will be moving to more clinical areas of wound healing. And we will start with one of the most common wounds, that is the extraction socket. So let me just load my presentation here. Oh, I'm sending a request for sharing. Somebody needs to open up the security. Okay, now I can get there, so that's good. All right, one more time. Everybody can see now me and my presentation on full screen, right?
Yes, we can see.
Yeah, it's quite visible, sir. Thanks.
Thank you very much. So let's talk about healing of the extraction sockets and the rich preservation of the tooth extractions. So as you probably know, this is one of the most common wounds that we do in dental practice most of the days, actually. And we will see how this healing differs from the soft tissue healing that we have already covered over the last 2 days. So when we observe sites where the teeth have been extracted, we often see some reduction of the height and or the width of the ridge. So it doesn't look like as wide as you would expect that to be before extraction. Like if you compare here tooth number 2-1 that was extracted to 2-1-1, the ridge obviously looks much more narrow. So and that may depend on the anatomy, and I think there will be some more discussion about how the anatomy can influence the outcomes of the healing that will be presented later on in my lecture. But some areas of the dentition naturally don't have a lot of bony housing around the teeth. So the bony housing can be really, really thin, or some areas like here in the lower molar and in the canine area, it can be missing for half of the root. And the most typical area is the lower anterior mandible, where the bone normally is about the same thickness as a printing paper, and many times the bone is totally missing. So if you have a huge bony housing and you take a tooth out, even if the dimensions change, that may be okay. But if you have thin or non-existing bony housing, obviously we might have a problem with the healing comparing to the what the site was at the beginning in terms of width and height. So if you just here is the example of the anterior teeth, where as I mentioned many times, the bone is labially paper thin, and some areas it can miss all the way to half of the root. And when you take, in this case, 2 teeth were lost and they were extracted. And about somebody needs to mute their microphone. So two weeks after, the height actually looks really, really good. But when you look at the 3 months after, there is some reduction of the height as well. But more importantly, if you look at the width of the ridge, when you take these teeth out, look like initially in 8 days. So the width of the ridge is actually very nice. It's the same as it was before extraction. So it looks like this will be a nice place to put implants, but if you don't do any ridge augmentation here, you can see how this area starts shrinking, and in 3 months, the bone is far too narrow for any kind of an implant placement. So if you don't do anything, we tend to lose quite a bit of bone, and we will discuss why that is and why that happens. So if you think about the soft tissue healing, and we will talk about that too, in the lower incisor area, the wound is pretty much closed in 8 days. So remember that the epithelium will cover the wound about 0.5 millimeter per day, and it comes from all directions. So it will be small wound will be closed in a week. But what happens after that, you have a significant reduction of the bone housing underneath. So periodontists and implant surgeons, they want to assess the ridges after the extraction has been done, and they have created these classifications that will help them to decide whether the implant, for example, can be placed without any kind of a augmentation of the ridge. So we measure mesial distal dimensions and buccolingual to find out, how many implants we can place there, and is there enough width clinically. We look at the occlusal clearance and anatomical structures and keratinized gingiva, and then based on all those findings, we also then try to classify and write this down in our patient charts, what kind of a ridge deficiency there is. So if you only have a deficiency on one side, which is typically the buccal side or the labial side, then you have a class 1 Seibert class 1 defect. If you have only reduction in height, you have class 2. And if you have both height and a labial reduction, you will have class 3. And this is fairly common to have class 3. So that means that the height has reduced and the width has reduced, and typically it will reduce more on the labial or the buccal areas. So some of the newer papers have reviewed, so this is relatively new paper, reviewed the healing of the extraction sockets and what's kind of known today about it. So basically, it follows the same principles that we already discussed for soft tissue healing. So you have the hemostasis coagulation within the first 24 hours, from the minutes to 24 hours, then inflammatory cells will come into the clot area. So the inflammatory states will start and will last for a couple of days. And then you have the neutrophils and macrophages and some lymphocytes coming in and secreting those growth factors and cytokines that we already discussed. And then the proliferation states will start. The only difference here is that at this point, the epithelium is pretty much closed. And on the side of the socket, there are cells that are making bone, and those are the osteoblasts. And then they will start invading the clot and making more and more bone, and then it remodels, and we have some bone formation a couple of weeks after that will be then will continue for several months to come. So you can look at this same kind of stages in a different view. So you have when you take the tooth out and don't put anything into the socket, you will have the hemostasis and coagulation for the first 24 hours. As I said, and here are all the players. Then you have the inflammatory states that starts in a day or so, and you have the neutrophils coming first, and then macrophages. And remember, then the macrophages have to switch from the pro-inflammatory to the repair states. So from M1 to M2, and then you fibroblast starts migrating the cells from the side of the socket, and will start migrating into the clot in the socket, and then also the cells from around the blood vessels migrate there. The cells at the lining of where the periodontal ligament used to be start proliferating, and they grow into the socket, and then finally the osteoblasts that differentiate start making bone for the socket. I have always asked my students that why does the socket heal with bone and not just with the connective tissue? And none of them have really given me a good answer yet. So I will seed that seed to all the participants in this course to give me that answer. Why does the socket heal with bone and not just leave a connective tissue clot? So there are probably a few speculations that you can give me later on, but I have always asked that from the students, so they have to think about how this all proceeds. There may be some hints coming. So here's the picture from those investigators that I was talking a little bit yesterday. What happens to the soft tissue, first of all, when you take the tooth out? So in this paper, they did a study where they labeled the progenitor cells. So they have these V and T responsive cells. So they are forcibly labeled. They are part of the junctional epithelium and few cells in the oral epithelium. And if you look at these green cells, those are the responsive cells. So they're basically stem cells for the junctional epithelium. And then when you take the tooth out, obviously, most of that epithelium will stay, or some of them will be lost. Because when you take the tooth out, depends how you look, say, some of those epithelial cells, they have a very strong attachment to the enamel or the tooth structure. So if you rip just the tooth off, some of those junctional epithelial cells will stay with the tooth, and some will be left behind surrounding the socket. So the question is that who are the cells who migrate into this wound? Because they are not typical oral epithelial cells, they are junctional epithelial cells that are functionally different cells. So what happens is that these cells actually start expanding quite a lot. And when you go to the day 7, when the epithelium has closed the wound, so again, depending on the extraction site, this healing, like I already demonstrated in the lower mandible, it will be closed in a week. And you can see how the massive the reporter cell expression is. So basically, all these cells, epithelial cells, came from the junctional epithelium initially. But what happens after that, when another week goes, this epithelium remodels, and these marker cells for the junctional epithelium, they disappear. So the conclusion was that after extraction, the remaining junctional epithelial cells actually participate in this reepithelialization process, but then they disappear and it becomes oral epithelium. So there are no functional remains of the junctional epithelium left. Otherwise, the healing will proceed as in the soft tissue in general, because you have the fibrin fibronectin clot in the socket. And remember that mucosal cells, they migrate through the clot, not underneath. If they will go underneath, they will go and line the whole socket with an epithelium, but they don't do that like the skin cells do. They just go and invade through the fibrin fibronectin clot, and then they fuse in the middle. And then in this case, the oral becomes oral epithelium at the end of the day. So what happens with the socket then? So Indy and Arau have done a lot of studies on this several, like 20 years ago, that are kind of classic to study extraction socket healing. Most of those studies were done in dogs, and I will present maybe 2 of them and some data from those studies because they are still probably relevant. So if you look at the extraction socket healing in these dogs and what happens with the buccal crest. So initially the buccal crest is higher than the lingual, but then it starts losing dimension. So in the 8 weeks, it has lost 2 millimeters of dimensions compared to the lingual crest. So there's clearly more. Please mute your microphones if you can, because sometimes we get some noise coming out. So clearly there's more labial resorption or buccal compared to the lingual side. And that's pretty evident when you look at the histology in that paper. So this is 1 week after extraction. So the epithelium has covered, as we already discussed, and become kind of an oral epithelium. There's some information left, but the buccal crest and the lingual crest, buccal crest is actually a little bit higher than the lingual. And here we have the clot and then provisional matrix in 1 week. So there's still no bone formation at the site. So this is where the periodontal ligament used to be, and it will participate in the healing process of the socket, because in 2 weeks' time, then the buccal plate has reduced to about the same size as the lingual. And at that time, you already in these dogs, you will see some bone formation at the side. So there's a differentiation in the bone cells. There's a little bit clot or woven bone present, clot and woven bone present at the time. Then after about 8 weeks, 2 weeks, obviously the epithelium is closed. Now the socket is also closed on the top. And there's kind of like a bone marrow with the variable amount of bone tissue inside. And then that will just keep getting bigger and bigger. But what happens is that the buccal crest is getting lower and lower. So we always tend to lose. We lose a little bit of the lingual, but much more on the buccal crest area. So that has some clinical consequences, especially when you are planning to place implants into these sites. So this is what happens if you don't do anything with the socket. So there's no augmentation of the socket of any kind. So it's called non-assisted or unassisted healing. So Farina and Trombelli from Italy, they have a look at these similar things from the models before and after extraction, again, unassisted healing. So the initial average mean width was 12 millimeters in their measurements. I can't remember exactly what size they were looking for, but then over time, these dimensions change. And the major change is happening in the first 3 months. So majority of the bone that is lost around the socket happens during the first 3 months. And then it kind of tapers off. So you have much less over the next 6 months. So let's look at the dimensional traces. So 6.1 millimeters is lost, which is about 50% reduction of the width of the socket. So this only measures the width because it's lost from both sides. So it doesn't count for the height loss at all, which is usually less than what happens from the dimensions from the buccal and lingual, and more from the buccal anyways. So this is what happens if you don't do anything with the socket. Obviously, there's a big variation from site to site, from individual to individual. So that was when the implant era kind of started the whole thing of we need to have bone in the right place for the best prosthodontic outcome for our implants. So the implants can be placed in an ideal or optimal location. So then people started placing all kinds of materials into the socket, looking at improving or maintaining the heights and the widths. So some of them have been reviewed, like I'm ahead of my time because this paper is coming out May 25. So they were looking, first of all, complications for extractions and influencing factors. So they listed all the complications that are not actually that frequent. I mean, the most frequent, they had trismus, that sometimes happens. So they had 14%, which is fairly high, in my opinion. They also have dry socket with very large variation in different studies. And then abscesses and osteomyelitis, bleeding, they are relatively rare. There always is some pain, but even percentage for those is not that high. Nerve damage is very rare if you, and that usually happens only in the surgical extractions when things go wrong. So there are patient-related factors that may influence the complications, such as smoking, alcohol, coagulation disorders, and some medications. And there may be other patient-related factors, such as oral hygiene, where the extraction happens, what area of the mouth, and how difficult the extraction is, how experienced the clinician is, may influence how many complications you have, and surgical technique, anesthesia, and a few other things may influence the outcome of the healing. So you can look at these dimensional changes from different angles. So here in this paper, they looked at the healing potential of the socket from various angles. So if you have a big bony housing, like this is a two-root tooth that has the socket and it's filled with the cloth, and then looking at the healing of these sockets, you have all three walls where those progenitor cells can come and heal and make bone for you. And if these walls are really thick, then the question is that do you actually have to do anything, put any graft into the socket? Sometimes we can't predict how thick these walls are. But ideally, if you have an intact wall all around the socket that is very large, then the healing outcome will be more favorable. If you have this kind of situation where you are kind of missing one or there's a dehiscence after the extraction, obviously, then the soft tissue healing will kind of go into this extraction socket partially, and the bone is not filling the socket all the way because there's a competition how this happens, and less available cells that can make bone for you. And the situation is a little bit different when you have a thin bone, like we many times have on the buccal or labial surfaces, where again, after the extraction, there are not many cells that can contribute to healing, so that the healing tends to be only from 3 different walls, comparing to the 4 walls in the more ideal situation. So there are some anatomical factors that clinicians need to consider when they are doing extractions. This is from some of the same authors. So you have to look at if you look at the CT scans, for example, if you are thinking about immediate implantation, you probably want to have a CT scan, or you are thinking about whether you want to augment the site. If there's an infection, you may want to take a CT scan, and then you're going to find all these things. So the anterior maxilla is a complicated in the view that the implants don't have the inclined crown, so they can be made inclined by the having a screw channel that is not going straight to the implant. So implants go more straight into the bone than the teeth go, because the crown is angled in the natural teeth, while it has to be made angled in implants, and that may require sometimes placing an abutment instead of a screw retained crown. Nevertheless, sometimes it's difficult to assess how thick the labial wall of the socket is, even from the CT scans, because if it's really thin, it tends to burn out. So you don't actually, sometimes you don't see much bone at all. And when you open it up, actually there is a thin wall of the bone. But if people have tried to make predictions based on clinical appearance of the anterior maxillary teeth, and then try to decide whether grafting of the socket is required or not. And we tend to fail the estimates that we make. So it's very difficult to know from the clinical appearance whether you have thick labial bone and thick gingival tissue without the CT scan anyways. So obviously this is more ideal than having very thin labial area. But if you are planning to place an implant on the anterior area and you suspect that this area is thin, then the grafting certainly will be indicated, because then, first of all, it will make your implant placement so much more predictable, and you can place them in the right angulation. The other thing that needs to be considered is the base of the bone, because sometimes the roots can almost come out of like in this image here in the B, the tip comes almost out of the bone. So if you take this tooth out, you know that you will lose most of that buccal wall, and it will just, the bone will shrink all the way down, and you will not have enough bone for the implant. And then again, there's also the foramen that is close by that will then take some of the bone away. And this basal bone, like in the image B, if you can see it, it's sometimes very narrow, so much more narrow than where the root is. So if you take the tooth out, you will have only a thin wall left on the lingual side and nothing to place the bone. Please mute your microphones, please. So in these cases, like if you take the tooth out, we typically, at least in our university, we tend to augment the buccal side and the socket at the same time because we know that we're going to need more bone for implant placement. So sometimes the socket augmentation becomes combined socket and ridge augmentation when we are predicting from this CT scan images what we actually need to do. So we have to consider the anatomy of the site as well. So in the wound healing book, there was a chapter about extraction sockets, and I expanded that list a little bit. That was listing the various factors that may play a role in regulating how the extraction sockets heal. So smoking is one important factor. The smokers, as has already been discussed, they're immunocompromised. The healing is typically soft tissue healing is delayed, and the hard tissue healing is delayed. If you have an infection on the site, so depending on the amount and the type of infection, we may or may not want to do socket augmentation at the same time, or we have to think about if there's an infection after extraction, and that may then influence the healing of the socket. Some studies show that flapless extraction, if it's done in a gentle way, will have less bone reduction on the labial side or the buccal side, but not all the studies will show the same results. And now extraction site may also regulate how much bone is lost during the healing phase. So if you have a tooth next to a dental site where bone is already dipping down where the tooth had been previously removed, and then you take the tooth out next to the edentulous site, you tend to lose more, at least distal or mesial, wherever the extraction site used to be from the previous extraction. So you tend to lose a little bit more bone if you do multiple extractions side by side. Chlorhexidine rinses, and I think there has been some discussions about chlorhexidine. I think SAIF will talk about those. We tend to routinely give patients chlorhexidine rinses after extractions that is supposed to prevent infections and improve the healing, although the evidence is not that strong, but nevertheless. And then obviously we have systemic factors, immunocompromised patients, coagulation patients who bleed, then the healing cannot proceed as normally, or you have diabetes that was discussed yesterday. So here's an example of a patient who is a smoker who had two teeth traumatized 10, 15 years before this image, and root canals were done. But you can see that the root canals are failing and there's a loss of bone, almost total bone in this area. So when these teeth were removed, a ridge augmentation and socket augmentation were done at the same time. I personally did one of those, and then my co-periodontist did a second grafting procedure. and those flaps were just sloughing down. So a heavy smoker who reduced the smoking but did not stop, the area did not heal that well. And if you think about how this all healed, this was with the infected teeth, so it looks pretty good. And then we have to compensate of the loss of the ridge, even after 2 augmentation procedures with 2 different surgeons. And we still lost dimensions quite a bit from the side. So the collapse just continued. And then the patient had lost bone even after implant placement into the area. So not necessarily a very pretty outcome, and we don't always show these cases, but the loss of gingiva has been compensated with the pink acrylic, and there's a collapse of the ridge, and most of this failing to heal is related to the patient's smoking habits. There may be probably other contributing factors as well. So infection obviously plays a role. If you take the infected tooth out, you will know that some parts of the walls will be have already been lost. So and typically they are lost on the site where the least resistance is, where the abscess has been. So typically most of the time on the buccal side, like in this case. So then also always the question can be made: is this going to need an augmentation of the socket and the ridge? And success of that will depend on many of the patient factors that we already discussed. So not only socket needs to be augmented, but also the ridge. And some people wait for the soft tissue healing, and then they go back in a couple of weeks to wait that the infection is cleared. But remember, when this infection abscess has been removed, the bacteria are not actually in the bone. They are hiding in the whatever is left in the root canal, and then they occasionally get into the space. So it's not like this is full of bacteria. The bacteria are confined where the root is. So diabetes was discussed quite a bit yesterday. There was relatively recent paper from Dana Graves, who have been studying diabetes and wound healing for most of his life. So they published a review a couple of years ago, and not surprisingly, they were talking about the complications in healing if the patient glycemic control is not to the bar, meaning that close to the normal non-diabetic patients have. So you will have those AIDS products, the advanced glycation end products that have receptors in many cells, and then they instigate the cytokine expression increase, like the TNF alphas and IL-1 betas, and persistent inflammation stays in the wound. They may change microbial diversity, although we don't know too much about it. And then they may change the function of the neutrophils, and they also regulate the MMB expression into the wound, and that all results in the delayed healing. And then if you go to the more of the connective tissue cells, you have problems with the cell apoptosis, you have problems with recruiting the right type of fibroblast. Remember yesterday we were talking about the wounds heal with all kinds of fibroblasts coming into the wound site and making the healing will happen. And then if they are disturbed by these AIDS products, then you may have problems. You may have problems with neutrophil killing the bacteria. You may have issues with the transition from the M1 to M2 macrophages. Remember, this is a crucial part
how the inflammation goes away. And if this is blocked by the hyperglycemia, we have a problem with soft tissue healing. And then if you have more of the regulation with DAMPs and BAMPs of the NF-kappa B pathway, you will produce more cytokines and inflammation persists and healing is going to be delayed. So obviously, diabetes can impact all phases of wound healing, where we do socket healing, or we do bone grafting for the rich, soft tissue healing. And if you have anti-resorptive therapies on the patient, and we will talk about that a little bit in the next slide, and combination of diabetes that will have very negative effect on the healing. So talking about anti-resorptive therapies a little bit, because we just have to keep that in mind, that it may influence the outcome of the healing. So the common anti-resorptive drugs in Canada are bisphosphonates and Prolia, which is denosumab. So it's an antibody against rank ligand. So the patients are commonly described these, and in these days they tend to have injections every couple of months. So the idea is that they will prevent osteoporosis from the osteoclast eating the bone. And osteoporosis is very common in elderly people, and there's a lot of old people who are taking these drugs. So in your practice, you will probably see patients who are on these therapies. So you have to think about how to manage them. And I'm not going to details how to manage these patients, but I'm just mentioning that it may have a effect on the wound healing on these sites. They have a different mechanism of action. I will describe that in a minute, but they have a small risk even if they are in oral bisphosphonates, or these every couple of months injections on the lower dose. And here's an example of one of the patients that we saw in our clinic a long time ago. So the tooth had a periodontal problem, location defect, and the tooth was not savable anymore. The tooth was taken out, and then the socket did never heal. So patient actually ended up losing half of the mandible for osteonecrosis of the jaw. And this wasn't an IV bisphosphonate case, it was an oral, that we think that the risk is small. And the risk is very small, but it's devastating if the patient will get this. So we do have a special protocol for extractions for any bisphosphonate patients. So how the mechanism is different between these two most commonly used drugs, at least in Canada. So bisphosphonates are the molecules that bind to the minerals, and then they kind of cause the osteoclast will then take them up when they are trying to resolve the bone, but the cells get frozen, so they are disabled to do the work. So this rougher border, the laguna, will kind of disappear, and the cells become smooth, and they sit on the bone, but they cannot no longer resorb. So that's how the bone loss is reduced in osteoporotic patients by bisphosphonates. And because bisphosphonates love attaching to the bone minerals, they stay in the bone for years to come. So the other drug that is used is the Prolia, which is the same as denosumab, which is an antibody, and it's an antibody against rank ligand. So rank ligand is involved in the differentiation of osteoclasts. So when you block rank ligand, so there's always a competition between the osteoprokeratine and rank. So if you block the rank ligand, then these cells can no longer differentiate to osteoblasts. So basically the difference is that with bisphosphonates you have frozen osteoblasts, but with denosumab treatment you don't have osteoblasts at all because they don't differentiate. So both may have similar kind of a osteonecrosis kind of symptoms in the mouth, even after extraction and sometimes spontaneous. There was one interesting study done some years ago about the long-term oral bisphosphonate and how that may delay tooth extraction, socket healing. So this is not the same as osteonecrosis of the bone. This is delayed healing because you have those bisphosphonates in the bone. And remember, when the bone socket heals, there has to be some resorption process at the socket wall that will initiate the process of then the coupling between osteoclasts and osteoblasts, so that then can make the bone. So, what they found in this paper that there was some delay in the healing of the extraction sockets in patients who had received bisphosphonate for many years. So it was more present in these groups 3 and 4. So between these patients received between 5 and 10 years, and these over 10 years. So they tend to heal a little slower. That doesn't mean that there's a bone exposed and it's necrotic. It just means that the sockets tend to heal slower, and it may have consequences if you are planning to place an implant into the area, that maybe you should just wait a little longer if you have a bisphosphonate patient who has received bisphosphonates for years and years, so over 5 years anyways. They also compared the groups with the other systemic factors and didn't find a difference between those two groups. So that was another finding there, but seemed to be maybe a little bit delayed healing in those patients. Then the question was asked years ago that whether if you just put an implant into the fresh extraction socket, can you prevent the loss of the labial bony structure, the height? So this was done like almost now 20 years ago by Linde and Araujo. So they compare what happens with and without placing an implant into the socket. And as you can see in these images, so this implant has been inside for four weeks. You have a little bit of a junctional epithelium, you have the connective tissue, you have the bone, and this is the lingual side, and this is the buccal side, and you can see that already there's quite a bit of reduction of the buccal bone, even if the implant is there, and it continues for the next 12 weeks. Fail to preserve the hard tissue dimensional changes after tooth extraction. So if you have a thin bony socket, and you immediately place an implant, that will not prevent the dimensional changes of the socket. So ideally, you would like to do this in a implant immediate placement in the locations where you have really thick bony walls. So even if you lose some bone, it's not going to sacrifice your implant placement. So going to the last part of my talk will be how do we then preserve the ridge? And now there are lots of all kinds of materials that you can use. And typical materials include membranes and bone grafts. So they can be resorbable or non-resorbable membranes, and the bone grafts can be all kinds of different origins. So let's review quickly those. So most periodontists know that we have different kinds of grafts that are used for these kind of procedures. And we typically don't go and harvest the bone from another location unless there's something else going on for socket grafting. So the autogenous grafts are not commonly used. Allografts and xenografts are used frequently. Alloblasts that are made out of synthetic materials are less frequently used. So allografts are basically donated bone from other people, so basically from cadavers, and xenografts are from animal species. So they can be mineralized or non-mineralized cortical or cancellous bone. So typically we use in Canada allografts for extraction sockets if implant will be placed. At least that would be my preference. And xenografts for those sites where the patient will choose to do like a bridge or no implant placement, because the difference in resorption rate, how the bone replaces those grafts, is different. So allografts tend to resorb faster and will be replaced by the patient's own bone faster than xenografts that can stay in the site for months, if not years. Then the bone needs to be covered with some sort of membrane, otherwise the particles may just disappear from, at least on the orifice of the sockets. So both non-resorbable and resorbable membranes can be used. So non-resorbables are typically titanium reinforced membranes that then need to be removed. And this advantage is that they has to be removed, and sometimes they get exposed, and many times they are left partially exposed. And then they may have some issues with the membrane getting more and more exposed. So my personal preference, I did try many of these cytoplast membranes, for example. And then because of the membranes being always exposed and sometimes causing some recession of the gingiva on the titanium membrane or the titanium reinforced membranes, most folks use collagen membranes that are resorbable because the studies don't show a difference. So you want to pick up the materials that have less disadvantages, like you don't have to take it out. It will just dissolve on its own. The soft tissue likes the collagen membranes more than titanium membranes because they can't, or reinforced, not titanium, but I should say Cortex membranes, or the polytetrafluoroethylene membranes, I should say. They are not titanium, they are made out of PTFE. So those membranes are not that commonly used. Some clinicians still like to use them. I prefer personally resorbable membrane. And then there are different kinds. There are cross-linked, not cross-linked, different thickness, different companies. And nobody can really tell what is the best for this application. and we will come to that in a minute. So basically, I will summarize that the bone grafting materials, the graft itself, and the membranes, there's no scientific evidence that one product will be better than the other. So you have a little bit of a freeway what kind of bone grafting materials you're going to use and what kind of a membrane you're going to put on the top of it if you just do the preservation. Then the question is that does every socket need to be preserved or the socket filled with the bone, because it will be costly for the patient to have that done. And I suppose the question is that probably the answer is probably no. But if you are planning to do or place an implant into this site where the extraction happens, and you can't do immediate implant for various reasons for most of the time, then do you want to preserve? And my advice would be, at least in the anterior maxilla, anterior mandible, and the premolar areas, I will probably recommend doing a rich preservation treatment. I don't think it's over-treatment, and I think we have an answer here. So this paper will discuss the advantages and whether it's over-treatment or not. Tooth extraction, the central incisor was removed, and then you can see how big of a deficit it is if you don't do any augmentation at the time. So the buccal or the labial ridge was almost completely lost, and you can't place an implant in this kind of environment. So their conclusions in this paper was that the alveolar ridge preservation is evidence-based, clinically validated, and safe for socket management, and helps prosthodontically driven treatment. So if you are planning to do an implant, and even sometimes with the bridge, it will result in a nicer outcome for the patient. It does not increase the new bone volume comparing to unassisted healing. So the quality of the bone in the socket, it will not get better if you put the grafting material as a scaffold so that the bone will grow in. So the bone amount will be the same. So again, there's no evidence conclusively which grafting materials or membrane type will provide superior results. And there's no evidence that the grafting will change soft tissue dimensions after healing. In fact, there was a time when the periodontists were trying to close the sockets with soft tissue, repositioning, basically coronally positioning the flaps. And we don't do that anymore. We can leave the collagen membrane exposed. It's perfectly fine. Because if you do coronally positioning of your flaps to close the socket or try to close the socket, it's not always possible, especially in the molar areas. But even in anterior areas and premolar areas, it could be possible, but it's not advisable because you will be losing the keratinized gingiva when you are pulling the tissue over, compared if you just let it heal where it is. So obviously, sometimes you have to do coronally positioning when you do large ridge augmentations and things like that. So then you have to deal with the consequences in those cases. So the implant success in these grafted sites is not different from non-grafted sites. So another paper have looked at the complications and cost. And they have looked like how many sites need additional augmentation for implant placement. So this kind of it's a good information to have, because you can look what happens in unassisted healing. So if you look at the number of these unassisted healing, we have near 60% of the sites need some sort of additional bone augmentation if you don't do the socket preservation or socket augmentation. And then if you do with allograft, for example, that drops to about 10%, regardless what kind of a membrane and what kind of or what kind of membrane you use on the top of the of the augmented side. So there is a big difference from 10 to 60%. So let's say that from 10 patients that you do socket preservation, only one, sometimes two, will require additional bone grafting at the time of the implant placement. While in unassisted healing, every second patient or even more will require bone grafting. So there is a difference. So if you are not placing an implant, obviously then it becomes more of an aesthetic procedure. Complications with bridge augmentation. So obviously same that we see that we can have infections, you can have membrane exfoliation if you have the Teflon membranes. You may have a wound adhesions with Teflon membrane, not so much with the collagen membranes. You may have bleeding, ulcerations. You may lose soft tissue dimensions if you are doing more coronally positioning of the flaps and so forth. But overall, the percentages are relatively low if you do socket preservations. So we are talking about the few percentages anyways. So basically, this is what you do. You fill the socket with bone grafting materials of your choice. You put the membrane at the top, and you will reduce the amount of the bone that will be lost during the healing phase. And then if things go right, like here is a case from my colleague, Dr. Irinakis, who removed this tooth, and you can see that the socket walls is very, very thin. Did a socket augmentation, waited with the healing, and then place an implant, and the aesthetic results, it's outstanding. So here's a case where socket was not augmented, and then you place the implant, and even in this case, the implant is a little bit too much lingual. So the assisted, if you have assisted healing, meaning that you graft the socket, you will have a better initial position of the implant anyway, so you don't have to put them towards lingual, so you will have them in more optimal site. And then bone augmentation needs to happen now at the time of the implant placement, and the implant osteotonicity is a little bit too much into the lingual side. While if you do augmentation at the time of the extraction, you may put the implant in a better prosthodontic position in the end. So extraction technique obviously plays a role. You know, if you do a lot of trauma, you tend to get more. If you damage the walls of the socket, you will have more trauma. So sometimes teeth are not easy to extract. So one technique recommends that you will break the tooth rather than the bone around it and take it out in pieces. And you have to be skillful to do that with periodontals. But then you may be able to place the implant on the same day because you don't destroy the wall. So gentle extractions without additional trauma are always recommended. So this concludes my presentation on socket grafting, and I would entertain some questions if there are any.
Well, Dr. HANNU, a wonderful presentation. If by the permission of the host, if I may just speak.
Yes,
Yes,
Uh,
we were just about to invite you for this episode.
oh, I'm sorry. I just,
It's okay.
grabbed the opportunity. So, Dr. HANNU, I actually, because of the initial technical glitch, I'm sorry we couldn't be formally introduced. I am Dr. Farooq Faraz. I'm professor and head of dental school in New
Nice to
Delhi.
meet you.
And so it was a beautiful insight into the wound healing and tissue engineering lecture. An amazing lecture. I must
Professor
congratulate.
Faraz, could you please just open your video?
please open your
Yeah,
video,
sure.
please, so that he can see.
Sure, sure. Just one second. Am I visible?
Yes, you are now. Thank you.
Okay.
Hello, I can see
So,
you.
yeah, thank you. So, thank you for such a amazing and wonderful lecture. And I'm sure there would be a lot of questions which may be coming up for this. And so I just wanted a bit of your insight into the procedure of socket shield. Now we know that, in order, especially in areas where the labial bone is resorbed, clinicians are now resorting to socket shield and trying to preserve a veneer of, the root. So we had done few cases of socket shield and they seem to work well. However, in one of our case, there has been, it was done about 5 years ago, and there has been a dehiscence. You know, that it was a ophthalmologist where we did a socket shield, and there's a bit of dehiscence on the labial aspect, and it just happened, and we are trying to manage it. So, what's your insight on this socket shield and the healing associated with socket shield?
Uh, yes, a few comments, like positive and maybe negative. So in our institutions, we don't, I don't know any periodontists here who routinely will do socket shield, although we are all aware what the technique involves. So many of us have been reluctant because they are not really long-term, blind clinical studies with the larger population showing what the advantage is and what the disadvantages may be long-term. So I can elaborate what the advantage initially may be, and that's obviously the whole goal of the shield is to have periodontal ligament and that piece of root preserving the labial bone. That's the whole idea. There are a couple things that may complicate the procedure. First of all, from the healing perspective, just from the healing perspective, Carring many years ago showed, actually did intentional studies leaving root tips next to implants, and he was hoping to make periodontal ligament around implants, and he successfully did so with leaving root tips next to implants. So then that may happen in some of the cases that actually the periodontal ligament, from the depending how the big the shield is, will start migrating around the implant, and you no longer have a full osseointegration around the implant. So that's the basics in the what may happen in the healing phase of these shields. The second thing that bothers me a little bit more is this. So implants have quite a high rate of complications, including peri-implantitis and peri-implant mucositis. So I can't imagine, like, especially if you have a patient with history of periodontal disease, and you need a shield. You leave a shield there, and then that shield gets periodontal disease. And then you have that next to your implant. So that doesn't really sound like a very attractive option to have. And then that little piece of root becomes a sequester, basically, and then you have to go and remove it. So the ligament formation there that potentially happens around the root tip, and then the potential complications of maintaining, and especially if there are any complications with the shield in present, because you're going to immediately lose the shield if you get like peri-implantitis on a shielded implant. I have never seen one, but I don't want to see one. I have seen enough peri-implantitis that I don't want to see periodontitis on an implant. So that's my little take. I don't have really experience with shield techniques. I know what the idea is, but I have these concerns.
I quite agree with you, Doctor, because I feel that, leaving the shield at times behind, there could be infection retained within the shield itself, within the dentinal tubules that are there. There may be bacterial colonies. And that may also, apart from the periodontal aspect or periodontal implantitis aspect of it, the shield itself could be, a niche or a source of infection at a later date if it's not, properly, if the socket is not properly sterilized and disinfected.
Completely
So thank you for that. Over to the host, please. Can you unmute, Dr.
Yes. One more question is coming from Dr. Sajjad. He's asking, what is your opinion regarding early implant placement compared to immediate implant placement, especially regarding soft tissue cover at the extraction site?
So from the biological perspective, we kind of discussed that yesterday a little bit, that immediate implant placement may actually maintain the remnants of the junctional epithelium that may then become a better soft tissue attachment to the implant, comparing to the cells that migrate from the oral mucosa or the oral epithelium when you place implants on extracted site where the, the socket has healed and oral epithelium has formed on the top of it. So you may have an advantage from junctional epithelial cells making these peri-implant epithelium. There's no studies that actually showing that that will be more advantageous than the regular placement, obviously. So it's a theoretical question, but I think the immediate implant placement, as we know, it doesn't preserve the bone. So if you have a lot of bone and you have an ideal location and you have the thickness of the buccal wall that you can verify and you have the soft tissue thickness, the success rate is the same. So if you have an infected site or some compromised site, I would not recommend immediate implantation, because it's, although the difference in studies is relatively low, but there are more failures, especially if you have compromised patients. Like in our own studies, we have with the other periodontists, we have found that, you know, if you have a smoker and you do immediate implantations, you will have less success than you will have with waiting the tissue to heal and then place the implant. So we are talking about immediate failures. Those are different from failures that happen, you know, during 7-10 years after the implant has been placed, but the implant doesn't basically take. So we have seen those in our own studies that if you have an ideal site on an ideal patient, go ahead and place the immediate implant. There's no difference. But if you have any either compromised site or the compromised patient, then I will be reluctant recommending immediate implantation. So you save a couple of months, but you may risk the whole implant success. The other disadvantage partially is that you have no leeway of the position of the implants when you do immediate implantation. So you are so dependent that you have an apical engagement of your implant. So you can't drill the implant where you exactly want that to be. So many times they end up being a little bit towards lingual because that's where the more bone is. So if you are really picky with your ideal positioning of the implant, then the delayed placement has an advantage.
Thank you, Dr. LARJAVA. I think we are going to close this session. After 1 minute, we will start with your next session.
Okay.
May I invite Dr. Rashmi to, after 1 minute, to start the next session.
घर से बाहर रहने के लिए हर महीने 2,000 रुपए देते हैं।
Hello. Hello. Hope I'm audible to all.
Yeah, we can hear you.
Okay. In case of any technical glitch, please do let us know. Greetings, everyone. I'm delighted to welcome you to another enlightening installment in our morning series. Allow me to introduce myself. I'm Rashmi Azim, your host to this session. I would like to extend my warm welcome to all attendees and distinguished guests. The upcoming presentation entitled Soft Tissue Grafting, Procedure and Healing will be delivered by Professor HANNU S. LARJAVA. Overseeing this session is Dr. Vandana, who serves as a professor and head of the Department of Periodontics at Shri Guru Ram Das Institute of Dental Sciences and Research in Amritsar. Dr. Vandana's expertise lies in periodontal diseases and dental implants and skillfully balances clinical practice with academic instruction. Her extensive knowledge and experience have made a significant contribution to this field. We are honored to have you with us, ma'am, and welcome you too. Over to you, sir.
Dr. Vandana, can you hear? Are you there?
Hello?
Okay, Professor Hannu, you can start.
Okay, thank you. Can you hear me and see my presentation on the screen?
Yes, I can see and hear you both and see the presentation as well.
All right. Thank you, everybody who continue to be with us for the second lecture of today. So then we will move to another kind of a healing tissue or healing or the procedure that relates to wound healing. That will be the soft tissue grafting. So soft tissue grafting, at least in Canada, is fairly common procedure in the periodontics practice. So I tend to do this on a daily basis on patients who have various mucogingival issues. So it's fairly common wound healing procedure, like almost more common than the extraction socket healing that we just discussed. So in some other countries, the grafting procedures may be less common that they are in Canada, at least at the specialty practice. So it probably varies. So when we have gingival recessions, obviously we have to do the patient examination first, and we do all those same examinations that we do for every patient. So many patients undergo full periodontal examination unless they have a very localized problem on one tooth. And then we don't necessarily do all these assessments, but most patients who have multiple issues, we will do full periodontal examination with the pockets and recessions, keratinized gingiva, all the rest of it. So we will look at the occlusion as well, because it may be a contributing factor. Of course, periodontal disease that may contribute or explain the recessions on the patient, whether it's localized, generalized. Tooth positioning, because if the tooth is out of the arch, it's more likely to have gingival recession. So soft tissue thickness plays a role, amount of keratinized gingiva, any frenal attachments, interproximal bone, soft tissue levels, radiographs, oral home care levels and habits that may also dictate whether we're going to proceed with any grafting procedures. Are there some oral hygiene habits that may be damaging, such as flossing cuts? We discussed the dentin hypersensitivity, aesthetic demands, and then whether the patient has operations or fraction factors present. So what's causing gingiva to recede? So they could be a mechanical trauma or periodontal disease that are the main factors. So even normal oral hygiene measures on a very thin bony housing and thin gingival biotype may cause gingiva to recede on the root. So the wrong brushing technique or flossing technique, like you can see in this image, there's a little floss cut. The patient puts the floss in and then pulls down. So there's a little cut and there's an initial recession forming. In the lower canine case, it's likely that there's no bony housing covering the root at the first place and very thin gingival tissue. So these are more prone to recede. Our patients have many times not good understanding why the gums or gingiva is receding, and they always ask these questions, what's causing it, and partially it's, genetic makeup, meaning that how thick the bony housing is around your teeth. So if the bony housing is this big, the gingiva will never recede because the bone needs not to be there. Otherwise, gingiva cannot recede. So sometimes patients don't have the basic understanding that if the bone is high and thick, the gingiva cannot recede on the root because there's no root exposed. So secondary etiological factors are the position of the tooth, rotations, proclinations, thin gingival phenotype that I already mentioned, high phenol attachment that can directly contribute, bone fenestration where the root is not actually covered by big bony housing, or the housing is basically missing, and then iatrogenic factors that we have caused as dentists, and sometimes the patient has caused if they have like a piercing on their lip that then rubs on the thin gingival tissue and will cause the recession to happen. Recessions are common. In this one study from some years ago, they measured that 58% have more than 1 millimeter over 30-year-olds, and 22% have more than 3 millimeters of recession present, and it will increase with age. More prevalent on first molars and mandibular anterior teeth. So surprisingly, in some of the papers, they have found only weak evidence for smoking or hygiene and traumatic toothbrushing for patient-related factors. So, but we always consider that anyways, and in some cases, like I have here a case where, let me see if I can get my arrow here. So we have a patient who has this disorder, Munchausen syndrome, that is kind of intentionally causing harm. And now this harm is caused by the toothbrush and aggressive brushing that has caused extreme recession on some of the areas. So where the patient is kind of doing self-damage. So traumatic, this is an example that yes, traumatic toothbrushing can cause problems. So it's one of those factors that we always need to consider. Site-related factors, the curvature of the root, the interdental papilla, thickness of the keratinized gingiva, and the baseline of the recession depth that also dictates what kind of classification it has. So the question is that the patients will always ask, I have these recessions on my teeth. They're a little bit sensitive, but they don't really bother me so much. So do I need to do anything? Are they going to progress? And there are not many studies that have looked long-term what happens with grafted side versus non-grafted side. So here's the one study where Agarwal from 2009. So it's not that fresh anymore. But in that study, they were following up at least 10 years, in some cases even 27 years after They had done grafting on one side and no grafting on the other side. So they have contralateral sides that were not grafted and the other sides were grafted. And those sites that were grafted had they were stable, and they showed some coronal positioning of the tissue that we call creeping attachment. But those sites that were not grafted tend to lose some more tissue, so there was more recession present on those sites, even with patients who have excellent oral hygiene and maintenance care. So the conclusion was that gingival recessions do show a negative prognosis over time in spite of good patient motivation, while the prognosis is improved after grafting. So does every site need to be grafting based on this information? Probably no, but at least it gives us some idea what's going to happen in the future for these sites that are not grafted. Obviously, if you have a big bone housing, you have minor recessions. Do we have to worry about it? Probably not too much. If you have fenestrations, the roots are not covered by the bone, they have thin phenotype. Yes, that may be a beneficial thing to do. And I will discuss what our rationales for grafting are, so when to do it and when just to observe in a bit. But let's talk about the classifications first a little bit. So the most common, the old classification is a Miller. And I mean, many of us are still using the Miller classification from 1985. I mean, the old periodontists tend to do that. So it was based on what kind of outcomes can be expected from the procedures. They were classified from class 1 to 4. And then the class 4 was the one where no root coverage was possible. So it was all based on how much tissue loss you have between the teeth. And this is something that you probably should show your patients when you're talking about grafting procedures with your patients, that you can show them that if you have lost interdental tissue, the full root coverage may no longer be possible. And then you have to explain to the patient so they are not upset when you are doing the grafting and then you are not successful and you will be only able to graft over on this level. So you have to kind of explain to the patient what level I should be able to get it in my own experience. And when you have class 4 recessions, then basically there's no grafting that will keep this tissue up, because you can't, the gingival tissue will always follow the bony architecture. If there's no bone there to support the soft tissue, it will never stay there. So it's not going to stay in empty space. I mean, there could be another lecture to talk about how we're going to try to preserve papillae, but I can already say that it's a challenge. But we are not going to talk about it today, unless somebody wants to ask a question. So the younger periodontists are using the chiral classification, which is similar, but it's kind of based on the attachment loss. So again, similar, this will be kind of a class 1 or 2 in Miller's, and then RT2 will be kind of class 3, and then RT3 will be class 4. So again, playing with the attachment loss on the size. So you can see if the attachment loss is more than what you measure on the front of the tooth, then obviously it will be very difficult to get any kind of a root coverage. What are the goals for root coverage procedure? Obviously, the ideal optimal goal is the complete tooth coverage, obviously, and then increasing the keratinized gingiva, perfect match of the color, contour, and texture with the surrounding tissues, reduction of dentin hypersensitivity if present, improve aesthetic outcome, prevention of any further recession, reduction of food trapping in some cases if we have a kind of a ledge on the tooth. It may improve oral hygiene because then the tissue may be more level. So when you're brushing your teeth, you are not missing the recession site where the gingiva is lower. And the patient satisfaction is always important. Just a few words about dentin hypersensitivity, because sometimes patients are referred to our office that their teeth are very sensitive. And as you know, here's a reference that about 1/3 of population complain about some sensitivity in their teeth. Especially here in the north, in the winter time, when it's really cold, your teeth may actually feel sensitive. But do we need to do any treatment for it? It's not a question. So typical sensitivities to cold, can be too hot, to touch and sweet. Acid is food, may trigger the pain. Pain is usually short, lived, and sometimes difficult to localize very precisely, and may depend on the emotional states of the patient. So we have to do differential diagnosis and rule out all the other factors, and we can then tell that this is true dentin hypersensitivity, such as fractures, caries, pulpitis, and so on. So erosion is causing the dentin hypersensitivity. So basically, we are etching the root surface, or the patient is etching it, and then there are dental tubules that have fluid in it, and the fluid movement will cause the nerve fibers to stimulate, and then that is felt as pain. So the treatment will be then in a minute, but there are many things can remove the layer, the blocking layer. So always we will get some layer forming from the pellicle, from the saliva. But especially acids easily erode the root surface. So anything that you put in your mouth, or many things that you put in your mouth, are acidic. So from acidic acid to wine and soda drinks that can be very acidic, all the way to coffee and so forth. So I had a patient a couple of weeks ago who was referred to me because of the sensitive teeth. And I did an exam, and I found out like there was only minor recessions, maybe a millimeter here and maybe a millimeter there. And then I was really asking the patient what she's doing, and oral hygiene was good, everything was good. And then we realized that she said that she's drinking water throughout the day, but the plain water was not her thing to do. So she always added lemon into this water. So she was basically eroding the little root surfaces that were exposed, and the teeth in general, whatever, like I'm drinking here, like every couple of minutes. So that kind of a management doesn't require doing a big connective tissue grafts for management. So we always review with the patients, because if you do connective tissue grafting to cover root surfaces, and then you have a 7 millimeter recession and you cover 6 of it, that remaining 1 millimeter may still be sensitive. So we never guarantee that root sensitivity is completely treated by grafting, because it's not necessary. So we have to go through all other things that the patient can do like not brushing after the meals where the pH, the Stefan curve drops and the pH is lower, and then if you go brushing right away, you erode your root surfaces more than you would if you do it an hour later, for example. Aggressive brushing with abrasive paste, and so forth. So the patients can use home remedies, mainly different toothpaste products that can help with the sensitivity. And there are many, and they have different, so not everything works for every patient, but they can try one, and then if that doesn't work, go to the next one, because they have different mechanisms. As you can see, some of them have strontium chloride, some potassium nitrate, stannous fluoride, arginine, calcium carbonate, fluoride. So they have different ways of blocking the tubules, and some are blocking the nerve impulses and so forth. So they can use combinations or the one that they find effective, and obviously avoid the acidic products that they are having in their diet. But you have to use these products if with the toothpaste, for example, for weeks, if not months, before you see the effect. So you can't just use it once and say that it didn't work. And then you can do office treatment for dentin hypersensitivity, obviously. So let's go back to the question that, okay, most people at the older age and some younger people have gingival recessions. So when do we treat? So here are kind of 9 points that I always go through in my own mind to make the decision. So the question is that, is this recession progressive? Sometimes the patient can tell, sometimes the referring dentist can tell, and if it's a patient of your office, you have the records. Is this a cosmetic concern? Like, does that tooth look too long? I don't like it, so if it's truly tooth exposed, maybe that will be the rationale to treat. Dentin hypersensitivity, I already explained that it cannot be guaranteed that the grafting will take care of it. So you have to be a little sensitive on that issue. Thin tissue type with no keratinized gingiva or tissue, frenum pull in the area, placing an implant with no or minimal keratinized gingiva and thin biotype, partial denture abutments with recession and no keratinized tissue, acceptable home care that we require for all our surgical procedures. You don't want to do this on somebody who doesn't ever brush their teeth. And you have to identify that the patient is a reasonable patient, that their expectations are such that you can fulfill at least some of those expectations. So many times we calculate that I ask in my own mind, do I have 3 of these points present in this patient? And if the answer is yes, I may consider doing a grafting procedure. If I only have 1, I may, monitor the site and then see whether it will progress or whatever else. Because if you don't have advanced recessions, a millimeter advancement of the recession, you can still do the cover. It's almost the same degree. So that's my own. Every periodontist obviously will make their own decisions based on what they think that need to happen before I make the call that you will benefit from having the recession. So you can always use the previous paper saying that, it will progress if I don't do it. But is that progression important enough for the patient that they want to go through that procedure? So what's the treatment? In the olden days, before we started, I'm old enough that I talk about the time when we didn't do connective tissue grafts. We only did free gingival grafts. And, I think the indications have lowered because the pre-gingival graft is not very good treatment for covering wounds. So it's a very good treatment augmenting the tissue if it's done properly. And not like in this case. This is an ugly pre-gingival graft. And here, the patient will have only benefited from connective tissue graft, but periodontist decided to do a free gingival graft. I mean, we still place free gingival grafts, but not as much as before. Like we have moved from the free gingival graft to the connective tissue graft with or without coronally advanced flap over the years. And now we do a lot of connective tissue graft instead of doing all free gingival grafts. So, I mean, you all know what the free gingival graft is. You take the full thickness piece of palatal mucosa and we place it to a new location to augment the tissue. So the difference is that you will always see a little bit, sometimes a little bit the color difference, right, or healed. You may put it in the wrong location where it's not actually doing anything. Sometimes it may instigate us, or you may have increased thickness, but maybe sometimes too much, and so forth. And sometimes it is just a small graft that will start because you can't do root coverage in this kind of a RT3 environment. Then you will be placing a graft to eliminate the Frenum pool and the thin tissue in this area, and you put the graft there so the Frenum will not go unattached to the same position anymore. So then let's move to the root coverage, the connective tissue graft that we, at least myself, I will do much more than I do free gingival grafts. So we have moved from the free gingival graft world to connective tissue graft world. And with combination of these pedicle grafts sometimes, so it depends. So sometimes we use coronally positioned flaps together, typically with the connective tissue grafts, double papilla flaps together with the connective tissue grafts. So sometimes these are used in combinations. I will discuss that. There are other techniques like using the acellular dermal matrix in different techniques. And then there's a pinhole technique that I will very briefly discuss today. But so there's various ways of harvesting the connective tissue, and it depends on the patient. This was mentioned a little bit earlier in this course, that how much you can collect mesiodistally and where you can go. So typically, if you look at the dry skull here, we can basically go typically from canine to second molar. And if you can recognize probably where the foramen is and where the blood vessels run, that's the width that you have to harvest. So typically we have enough, but if the patient has a very shallow palate, you actually may have very limited amount of tissue. So this is the way, I mean, the difference here between the high palate and shallow palate is from 7 to 17 millimeters. So, and the length varies from 20 to 30 millimeters of length. So that limits how much you can get from one side. Obviously, you can go to both sides and then you have double of the amount. So I harvest my graft this way. You can harvest whatever technique you want to do. So I do a incision about 3 millimeters straight to the crest, and then parallel incision, parallel to the palatal vault, down, and I harvest the entire tissue with the periosteum included. So there are techniques where you do 2 incisions, and you just take the slice in between them. I found it easier to do it harvesting the entire tissue that is shown here. It probably doesn't make a difference if you do it one way or the other. So what can we expect? Increase with keratinized gingiva, root coverage to some degree. So the large variation in studies in Miller class 1s and 2s, or the RD 1s and 2s, so 9 to 96%. Obviously, some clinicians are really good, so they get to 96, and some only get to 9% of the full coverage. So the mean root coverage is typically 65 to 97%. So I always tell the patients that you get something between 50 and 100, depending on the recession type, of course, but in the ideal situation. And the average is 75. So if you have 3 millimeter recession, you may get 100% coverage, or you may get 1.5 millimeters coverage. My average would be 2 millimeters. And you all have to say what your numbers might be. So they are probably different for every clinician. You may get some reduction of the dentin hypersensitivity. We don't go discussing the interdental papilla at this point because they are very unpredictable to graft. So typical connective tissue graft in the original techniques, you open a flap, then you place your connective tissue underneath, and then you either coronally position or repositioning the flap so that the tissue can be exposed or fully covered. We try to fully cover it if possible, like you can see here. Recessions, very advanced, 3 to 4 millimeters with some frenal pulls that we eliminate during the procedure. And then you coronally position the graft, the flap tissue over your connective tissue graft. How about the biology? How does this connective tissue heal when you place it into that defect? So there are a few studies, and I think this is from the early 2000 study by Caffese and other folks who were looking on the dogs, the grafting results. So in about 7 days, you can see that the graft is here. So you can kind of see that it separates from the gingival flap. There's a clot in between, and there's a little bit clot also between the root surface and the graft itself that is marked here as G, and there's some blood vessels forming. So this will be the healing about 7 days after. You can see that the epithelium from here has already migrated almost all the way up to the root surface. And the healing otherwise will proceed here as the soft tissue healing that we have already covered. The difference is that the blood vessels tend to grow into the existing blood vessels in your graft, and the graft will take. It obviously will remodel, but basically the cells survive that you transferred with your graft into new location. So it's not like the cells will die and then they'll be replaced by the tissue, by the cells from the surrounding tissues. When you look at the healing at a month later, so it's kind of hard to see exactly where the graft was, but it probably was here. I don't think this is an artificial line here. So, or maybe it separates still because it's not completely mature tissue. So you can see that there's a sulcular epithelium that has formed, and then you will see that most of the graft is attached to the root surface by long junctional epithelium, and then there is some new connective tissue attachment at the bottom. So it's a combination of long junctional epithelium, because the epithelium typically migrates down all the way where we attach the root surface during our clinical procedure. There's no bone formation or cement formation in this area because the epithelium is so fast migrating all the way down. So there's a small amount of connective tissue attachment underneath. So that's how these grafts typically heal. They fully integrate and they do attach, so they don't leave a pocket. So they attach by long junctional epithelium. So I have few slides from the Cortellini Quiniquato paper a couple of years back, looking at the whether you just have to do a coronally advanced flap, or can you or do you have to add a connective tissue underneath? So they have followed in this paper. This was published in Period 2012. So they look for the full coverage, and they initially have almost everything full covered, but you can see how the coronally advanced flap alone will not be stable compared to having a connective tissue graft underneath. So it makes it more stable. So the same is kind of evident when you look at the complete root coverage percentage. So this is with the coronally advanced. So you have in this study close to 60% full root coverage, and with time it drops to about 30%, so into about half in a year. So coronally advancement alone, without any connective tissue grafting, will give you about 30%. Let's say in 30%, it will give you full root coverage. As compared to coronally advanced with the connective tissue graft, you may initially have a lower full coverage rate, but we have an advantage in this case with the creeping attachment, because the tissue thickness has been advanced, that it will keep going up. So you have, in the end of the day, you have 50% full root coverage comparing to 30%. So adding the graft is no complicated procedure. So most of the time we add connective tissue graft when we do coronally advanced flaps. That's from their old publications, how they do it. And I will discuss how I will treat this kind of a recession. I will probably not do coronally advanced flap in this case. I will do it differently, and I will explain how. And here you have multiple recessions. They put the graft covering all the roots, and then they coronally advanced. So, and with nice results, obviously. In that paper, they were also discussing what would be the kind of a gold standard if we really want to cover the roots. So they were comparing the papers from a coronally advanced flap alone. So coronally advanced flap alone with the barrier membrane, coronally advanced with the acellular dermal matrix, and the blood-derived, platelet-derived growth factors. So they felt that it's superior to do coronally advanced flap with the connective tissue graft, being the gold standard. And in some cases, you can do coronary advancement plus enamel matrix proteins. So if you look at the amount of keratinized gingiva, the gold standards look similar. So again, the best treatment always comes with the coronally advanced flap with the connective tissue graft. And then equally good results sometimes are coronally advanced flap with the enamel matrix proteins or endogain. And then the other procedures are not so predictable. And they look at the cost-benefit ratios, and you know, we can discuss that another time. In terms of aesthetics, so if you have an aesthetic area, you don't necessarily want to do a thick connective tissue graft because it doesn't necessarily look very good. I will show you an example.
Dr. Rajab, I wanted to ask one thing, that your grafting tutorial is also included in this, or that will be taking afterward after this you complete this lecture, this presentation.
What was it? I will cover the grafting, obviously.
Okay, that is tutorial. You have got another thing is tutorial aligned. So is it the same? You are in presenting continuity, or you will break for this? Then you will.
I will break briefly for 1 minute.
Okay, okay, because we have got different person to chair that. That's why I'm asking.
Yeah.
Okay.
So I will stop. I hope that I have still a little bit more time to go through this phase before we move to the last presentation.
No problem.
Minutes. Okay.
No.
So let's go back to the aesthetics and what kind of grafting. Let's say this is more or most applied in the maxillary anterior region, where the aesthetics is the most important. So there, coronally advanced flap alone or combined with the enamel matrix proteins, or then I think the most predictable will be the coronally advanced flap, but relatively thin connective tissue graft, not like a hugely thick graft, because it will then not necessarily look very good. So I will show you like some of the grafting sites. If you do a really thick connective tissue, they may not look aesthetically very good. And again here, and in some of the cases, there could be even some induction of the bone underneath, because the periosteum has been stimulated. So it's not always the thickness of the graft, but it's a reaction of the grafting procedure. But typically, the grafts in the anterior maxilla should be maybe a little bit thinner than they could be in the molar area, let's say, where you can add as much as tissue as you want, and it's not going to bother anything. So long-term results, the greatest stability is always with when you combine connective tissue graft with coronally advanced flap. But there are other ways of doing it, and personally, I don't always do it exactly the same technique as it has been discussed here previously. So then the question is that what are you going to do with the root? Do you have to do anything? So there's not a lot of scientific evidence, but there is enough evidence that there's no advantage doing a special treatment on the root surface. So I'm old enough that I have lived through the citric acid cycle of periodontic, and we don't use citric acid anymore before grafting or EDTA, although some people may still be using EDTA on those roots that they want to cover. Some may use sodium hypochlorite, but there's no evidence that any chemical treatment will make this procedure more predictable or better. So the mechanical treatment is the recommended choice. And there are no exact requirements for that. So it can be your ultrasonic instrument, it can be the polishing or hand instruments. And personally, I have curettes on my tray. I always root plane the roots that I'm planning to place a graft. So it's a simple procedure to do. No chemical etching of the root surface is required. So again, if you have thick phenotype, then you could do coronally advancement, and you may do it with the enamel matrix proteins to get a little bit more better results. At least there's some evidence that that could work. If you have thin, then you probably would like to do a connective tissue graft. So let me just put all these things there. So if you have a very advanced single recession, and typically on the canines, the most predictable procedure is the double papilla flap over your connective tissue graft. So let me explain how I do it. I mean, if you want to try it in the clinic, if you haven't, some may and some may not. So I open the flap so that I can, to the level where it's not mobile yet, then I suture. Of course, you have to, you know enough of the wound healing that you have to create a fresh wound around these sites that you want to fuse together. So you remove the epithelial lining from this area, then you open enough so you can actually put sutures and close these. You close the wound in the middle like this, and then this can be all, and maybe it should be all partial thickness, and then you're going to go full thickness, and you can do a periostal release if you want to coronally position this flap. So, and then because you are coronally positioning, you have to de-epithelialize the papillae. Otherwise, you can't have a attachment of your new flap going higher on the tooth. And you may want to do the coronally advancement higher where you want the tissue to be in the end of the healing. So you go over. And like here, you have many times we have good tissue both sides of the recession. And if it's a single recession, you just make incisions here. You put these two pieces together and connective tissue underneath, and it's very predictable. So another sample of the double papilla technique with connective tissue graft. I never do these procedures without the graft underneath. So you suture that first, and then you suture your tissue over. And when you are coronally positioning, you actually can almost close all the sites, although you are closing it in the middle. So then we are coming to my most common procedure here. It's not the best example because this is going through orthodontic treatment, and some grafting is required for these teeth. So an envelope technique that was initially described by Ratschke many years ago, where you are just releasing the tissue and putting a tissue underneath many times without sutures, and I will explain this a little bit more in details. And when we are doing this without suturing, you place the graft into the pouch or pocket without sutures. You have to secure the graft by something, and that something will be either hystoacryl or Periacryl, which is a similar product but has a different chemical cross-linking. So it's not necessarily butyl 2 cyanoacrylate, it's a different kind of cyanoacrylate, but it works the same way. So the idea is that you are using tissue glue to glue your graft to the gingiva and into the tooth surface. So it has been used since 1970 in Europe, and I don't know if it's approved in India for using for these procedures or not, but in Canada we use it all the time. It can be histoacryl or periacryl, and they can come with different kind of strengths or different liquidity. So some can be thicker and some can be more running cyanoacrylates. So the only issue with these is that the glue is not very strong within the first 20 hours. So it's brittle, so the patient needs to be careful for the first 24 hours. And after that, it's equal to sutures. So the other thing is that the glue is sticky. I always put Vaseline on my glue so it doesn't stick, especially after this. So this was a patient I placed a beautiful connective tissue graft, and I tissue glue it, and the patient went home, put the gauze inside, dry, and slept, and then the gauze attached to the graft, and then everything was ruined. So you have to be careful. The patient needs to be careful when we are gluing things together. So here are a few examples. So we just use periotomes, special periotomes or ophthalmic blades to create a pouch. And how I do the pouch is that if this is the tooth, I will, the pouch will be this large. It's not like in the original Ratschke technique from 1985. It will be much, much wider elevation. So basically, I also release the papillae from the crestal bone, so the whole thing moves down. So when I place the graft here, I can partially coronally position the envelope up before the glue has been applied. Part of the graft can be left exposed up to about 3 millimeters. You can see here that the graft has been left exposed, and that's just tissue glue placed. Here, even more than 3 millimeters have been left exposed, and we still get nice results, and it's not very invasive. We have no sutures in the area. So the patients really like the glue will come off within the 4 to 7 days, and then it's just keep healing from underneath. So patient report is very good with this kind of procedure. So you can also use I don't know, I have this green thing here. Maybe you don't see it, I see it. Okay, now it's gone. So you can do the envelope again. We always release the neighboring papillae. If you do more teeth than one, then you just keep loosening the papillae. You can use the class 5 instrument that is used to help to make composite restorations, and then you can put the graft into that space. So you can harvest one graft, divide it to two teeth or 3 teeth, and then you put it underneath, and then you glue it. And then they heal typically very nicely. So here's a case with the 3. So 3 teeth with about 3 millimeter recessions. This has been all released, then the grafts will go in, and healing is is very nice. So another example where the instrument has been used. And then this is after healing. You can see pretty nice results on all, and it's all using the envelope technique, but modified that the papillae are also loosened. So you can actually coronally position the whole thing to some degree and just leave the corner of the graft exposed. So you should not leave more than 3 millimeters of the graft is exposed. There's a danger that that graft corner will die and the whole graft may be lost. So there's a limit how much you can leave exposed. So similar kind of thing. So this is my to-go procedure if I do grafting. Even on the lingual side, you can do like a tunnel if you like and have one graft underneath, or you can do single. Sometimes we have the CEJs are at the different levels on the teeth that you want to graft. So if the CEJ is at the different levels, if you put one graft, it's hard to position the one graft so that it's at this level on this tooth and maybe that level on that tooth and again that level in this tooth. And if the CEJs are not parallel, it's hard to use one graft to cover it. So single graft will adjust the problem. And the other thing is that many times we have nice keratinized papillae that we are kind of wasting the graft tissue when we are placing it all the way there. So if we do individual graft, we don't have to harvest as large graft as we have to do if we use a single long connective tissue graft. Let's move on. So that was the tunnel technique with the single graft that we kind of already discussed. What happens with the teeth that have other problems, such as abrasions or abfractions? So, first of all, the patient needs to be informed where the level that you think that you will be able to do the grafting for. Like if you have teeth that have lost the thin enamel at the neck of the tooth, obviously the normal anatomical position of the gingiva was never here because you have lost the enamel at the neck where it's very thin. So you have to show the patient that we will probably likely not be able to get the coverage all the way here. So it probably will follow the line. And if they are still not happy, small composite restoration can be placed after the grafting procedure has been done to replace the loss of not be able to cover crown denting. So we can only cover root denting. So patient needs to understand the level, and sometimes you have to show them in the mouth. So yes, if they are not very deep, so we say that if they are millimeter and a half, we can easily grafting. If they get deeper than that, like a 2-3 millimeters, then you might need a restoration. How about the crown margins that are exposed? So if they don't have restorations, you can do a graft to cover the exposed crown margins and get the gingiva to the level of your crown margin, so it will be aesthetically nicer. If you have composite fillings on the roots already, like in here, you will, if they are not very deep, and again, we say that if they are like less than a millimeter, less than 2 millimeters, we can remove them, and then we can do the grafting procedure And what is left when it's all healed can be then covered by another composite if necessary. So the procedure, we can remove the restorations graft and then do another composite for the remaining where the normal level of the gingiva needs to be. So what's the advantage of doing this kind of an envelope pouch technique? You don't need vertical incisions, you don't need sutures, but you can still coronally position using the advantage of the tissue adhesive, the glue. You can do single or multiple teeth. You don't waste your donor tissue in the interproximal sites where we have nice keratinized gingiva. So you need less tissue, there's less trauma. You get increased keratinized gingiva when you leave your graft partially exposed, and it will always result in a better patient satisfaction. So what we do after the grafting procedure, the patients have rinse for 2 weeks minimum because they should not be brushing the area. They have some sort of pain medication, whether it's ibuprofen combined with acetaminophen in Canada, a typical combination. Some patients may get Tylenol 3 with codeine. Some periodontists like to use for a couple of days, especially if they do multiple grafting sites to reduce the swelling in the area using steroids such as dexamethasone, but only for limited time, and that will obviously help the healing, help the pain as well if you do large areas of grafting at the same time. No brushing the site for 2 weeks, no flossing for 4 weeks, avoid pressure at all times, and no exercise for 2 to 3 days. So what are the complications? Pain, obviously. Some cases bleeding, it's not usually very prominent. Swelling, common infections, very rare. As I mentioned before, we don't give patients antibiotics when we do connective tissue grafting procedures. We do give them pain medications because that is a complication from the surgery anyway. How about the creeping attachment? I have shown you some examples of that already. So, if lessons, this is from some of the older studies showing that if there's a not full coverage at 4 weeks, over the next several weeks, we can get more coverage by just waiting, because what we call is a creeping attachment. If the tissue thickness has been increased, the tissue tend to grow down and cover more of the exposed root that what we initially saw when we do connective tissue grafting. And you saw some of the examples that already, that what we call creeping attachment. We don't understand the biology 100%, but it happens in 95% of the cases, and average being 0.8 millimeters. So that will help us. It may look initially that I did not get full coverage, but maybe a couple months later, the creeping attachment has helped us, and we actually have a full coverage on the tooth. So removing the epithelial lining from my harvest, I don't do it. Because some people have tried to do it, and then there's still some epithelial cells left. So obviously, you use a pouch technique, you put the epithelium up and not down. And that will complete my grafting lecture, basic lecture, and then we have a little bit time for in the next presentation to talk about the related issues and maybe look at some of the cases, what you would like to do in a case that I will propose. If you don't answer, I will give my own opinion, but let's see how it goes. So thank you for your attention for this presentation, and now I could answer some questions, and I think you have to change the moderator anyway, so thank you.
So I asked Professor Vandana to please unmute herself and please summarize the Professor Vandana, please unmute yourself.
I have unmuted, Seth. Are you listening? Am I audible?
Yes, yes, yes.
Am I audible?
Yes, yes, you are
Thank
audible.
you, sir, for such a wonderful lecture. And I'm feeling privileged to be a part of this wonderful session. So I have done few cases of gingival recession. I I want to sincerely admit this, that the only successful ones were just 2 to 3 mm of recession. And one thing I will like to ask is, what about the loss of buccal bone? Can we regenerate that? And what about the role of collagen membranes in recession coverage?
So there, regarding the membrane use, the membranes have been used for, and there's more studies and more companies wants to create new membranes. And in our institution, we may be testing one, whether it will be equal to connective tissue grafting without the need of harvesting grafts. The problem with the membranes and acellular dermal matrix is that these cannot be exposed, so they have to be coronally positioned to fully cover. And sometimes that is not very easy thing to do in the certain areas where we don't have enough tissues to pull over. So they require, the membrane treatment requires coronally positioning, and coronally positioning will by itself will have some level of success. So membranes have been used and they have some success. I haven't really seen a longitudinal studies comparing coronally positioned flap comparing to the, I mean, in one of the presentations from that peanut butter study, there was a barrier membrane in that scheme, if you remember, and still the connective tissue graft with coronally advanced flap was superior to using the membrane. But there are not many studies comparing coronally advancement alone versus membranes. So some studies show that the membranes will be helpful covering recessions, and various membranes from different companies have been tested, but there are not that many good studies on. And as I mentioned, they need to be fully covered, because if you leave them exposed, they will not do the trick. So you have to do coronally advancement over the membrane. Regarding the bone formation, there's no evidence even with the membrane that we will actually get much bone with these grafting procedures. So getting back that buccal bone seems to be a difficult task. Some folks have used the bone grafting products with the membrane with some level of success, but the gold standard remains just the connective tissue graft with or without coronally advancement of some sort, like we do. I personally do a lot of envelope technique or the pouch technique, which is similar to the advancement without vertical incisions and so on. So the membranes in some clinicians' hands seem to be working, but they need to be fully covered. And sometimes that will create another problem, like if you don't have keratinized gingiva, that will then not give you much more keratinized gingiva necessarily, because you don't have the connective tissue that will induce, like when you do connective tissue underneath the mucosal tissue, even if the mucosal tissue is maybe a millimeter to a millimeter and a half thick, the connective tissue that you place will induce the differentiation of the epithelial cells and will make you more keratinized tissue that the membrane will not do because the membrane is not connective tissue.
Thank you, sir.
Thank you, Professor LARJAVA, and thank you, Professor Vandana. Now, I invite Professor Zeba Jaffrey to chair this session, and Professor LARJAVA, you may continue with your grafting tutorial. Professor uh, Zeba will be sharing this session. Over to you,
Okay.
Professor
Thank you,
Zeba.
Saif. Dr. Saif.
Yes,
Thank you.
thank you. So, yes, you start, please.
So, Saif, do I continue right away?
Yes, you may continue, sir.
And the same question, can you hear me and can you see my presentation?
We can see you and hear you, but can't see your presentation right now. I think you haven't shared it. Slides are not showing.
So let me end the show and come back here. Let's see what happens now. Can you see my screen now?
Yes, we can see.
There's a dog on my screen. Do you have a
Yes.
dog on your screen?
Yes.
And you can hear me, okay?
Yes.
So, so we will continue a little bit with this tutorial. So, and now I would like to invite questions and Saif, maybe you can moderate or get the questions to me if they come in the middle of the session. So here's my friend who has been helping me to prepare some of these slides, whose name is Honeybee, although she is not collecting any honey, but he's Honeybee anyway. So I was thinking what this tutorial could be. So it's kind of a continuation on my lecture, but it has a few slides where I would like to get some input what the audience will do on some of the cases that I will present. But I will continue talking about some early healing and complications and how the healing outcomes may look like for folks who haven't done a lot of these procedures, and how you could quantify the changes in your office. And then we have cases for discussion, and that's kind of the more of a traditional tutorial part of the presentation. So let's see if we can run this a little bit. So we have a single 4mm recession of the lower premolar. I'm not running the whole video. So you do your root conditioning, but only with the instrument. So you remove the smear layer or any bacteria.
Professor LARJAVA, your video is stuck.
Hello, I'm back.
Yes, we can hear you.
Hey,
Yes, we can hear you.
okay, so let me just find my presentation. Just 1 second. I was just kicked out completely. So let me go back. In here. Sorry about this. This has happened before. With the videos.
Yes.
So I will not be running that video because it's it will not cope with my presentation. So I'm going to move to the next slide. I wanted to show you how the bounce technique is done, but I don't want to lose you and go back and forth. So can you see my screen now and can you hear me?
Yes, it can be seen. Can see it.
Okay. All right, so let's look at what are complications and what are not. So here is a single recession that the patient wanted to cover about 3 millimeters. And then we did a connective tissue graft with the pouch technique. So this is immediately after. Excuse me. And then the patient phones in later that day and says that, there's a bleeding from my graft site. And this is very rare. You don't do anything. Like you don't go to disturb your graft. So this was just dealt with compression and new tissue glue on the site. And the healing proceed without any complications. So if you see something like that, and there's a diffuse bleeding, which is rare, then you just do local measures. You don't go poking your graft because you may disturb the whole graft healing, and that may destroy your outcome. So here we have a tooth that has advanced recession, and there's a frenum in the area, and you release this. You can do this still with the pouch technique. If you release these papillae far enough, these margins will get closer. You can actually almost close them and then put your graft underneath. And you can eliminate frenal pulse from the inside of your pouch. You don't have to do any cuts in the outside, and they will still heal. So here's a case where we have a distal bone loss. So you don't expect to get full coverage on this abutment tooth, but you can see that the gingiva is very thin. So you would like to have some more gingival attachment and keratinized gingiva here. So this is how it looks like in 3 days. And this is how it looks like in 4 weeks. So we have about 50% or more coverage. And that's what we will expect in this kind of recession, where distal bone level is lower than the normal bone level would be. So if you see this kind of a healing response when the patient comes back, that means that your graft has necrotized. So the graft has died, at least the top part of it. If there's no smell or signs of infections, I don't usually touch these. I let the tissue to heal so that it will exfoliate the necrotized part, because you may still get a small amount of coverage, and then you have to obviously redo this procedure. So in our office, we tell the patients that if I don't get the results that I anticipate, or you are not happy with the results, we will do a touch-up procedure 6 months later if there's a reason to do it, and we don't charge the patient the second time. That's a courtesy of our office, how we operate. And there are a few cases where the gingival tissue will heal such a way that there's more shrinkage and you didn't get the coverage that you anticipated you will get, that's your average amount, or the patient feels that, I would like to have some more. So no questions asked, we will then do what we call touch-up procedure. And I remember one case where I had to do it 3 times when it actually worked. So, and we charged the patient only once because it was immediate. Then the patients ask questions that, we get nice results, and then they ask, is this going to last? And in most cases, we only have to do it once. The augmentation should be sufficient, and if their oral care habits are such that they don't aggravate the situation, if they brush the graft off, they can do that as we have shown. But most of the time, we don't have to regraft like every 5 years. It's a one-time thing. And in occasional cases, we may have to do a touch-up, but rarely. So when we have this course is about wound healing. So how does the donor site heal? So we have done some studies comparing let me see if I can. So now I'm not connected to my speaker, but hopefully you can still hear me.
We can hear you.
Without lots of noise from the background, hopefully. So we have compared healing of the pre-gingival graft that leaves an open wound to those with the connective tissue graft where we can close the wound. So the difference is that this harvest is more superficial than when we do connective tissue graft harvest, that we go deeper, and as I explained, I will harvest all the way from bone. So it's a deeper harvest, but we can close it compared to the thinner harvest and more superficial harvest. So we were looking how they heal, and they both heal pretty much without scars or minimal scarring. So this is after day 9, and this is 3 years, and this is 5 years. So it's very hard to tell that anything was taken from the roof of the mouth. So a good example that the palatal gingiva or mucosa will heal without scars in most cases, and there's no difference whether it's a little bit deeper harvest or more superficial harvest. So we used the modifier scar morbidity scale to actually measure the healing from all these cases that we had after various years on different patients, but we are trying to find out how they actually heal. And in both cases, we didn't find statistical difference between the FGGs and connective tissue grafts. We noticed that in the scale, they don't all heal with absolutely without scarring, but the scarring in general is minimal in both cases. So let's move on. So how about the other techniques that other investigators have used? And I have met Dr. Shao, who is running the Academy for Pinhole Technique. And I don't know how many of you know what the pinhole technique is, but there's a website for you in this in the handout. So if you want to go and investigate that, you can find it out from the website. So they have nice pictures how the patients have healed after doing the pinhole technique or multiple recessions. Until now, they really didn't have a lot of scientific evidence that this technique works, but this year they have a case series, is the first publication that they came with, that they were showing that their technique was comparable doing connective tissue graft on a single site. So what they usually advertise this technique is good for when you have multiple sites that you need to do. So basically in the pinhole technique, if you don't know the technique, is that you do like I do in the pouch technique, but you release the whole area and you release it with the incisions that you make into the vestibule. So like you look from the apical to coronal instead of releasing from the coronal, what we do in the pouch technique. So so you make little, you have a special instrument, you make little holes, and then you release the entire mucosa that it will move then down coronally in the maxilla and up in the mandible. And then you place collagen strips underneath the papilla, so that helps with the coronary advancement, and also all along of the underneath the gingival tissue. So you put these gingival stripes or the membrane stripes all around underneath. So and you can do the entire maxilla in one session if you want to. So some people use this quite a bit for multiple recessions because there's an advantage that you don't have to harvest anything. It's fairly expensive because you're going to use a number of those membranes. So it can be even more expensive than connective tissue grafting is. The results are variable. I have used it for some cases, like here we did pinhole technique for the lower teeth. We were not looking for full coverage. We were looking for increase in the coverage, and you can see that we were able to do that to some degree because you can see where the restoration level is. The restoration is now there, and what the coverage is on the canine and so forth. So we did get coverage for most of those teeth. So I'm not routinely using this technique. It has an advantage for multiple generalized recessions because it doesn't require harvest site from the roof of the mouth, because you just use the collagen membrane stripes to bulk the tissue. Then there are other techniques that are similar that use the alloderm, acellular dermal matrix that you can purchase, which is not too expensive, or it's basically a cadaver skin that has been processed, so it doesn't have any cells, and it doesn't have immunogenic response. So it's basically a collagen matrix. So you can put it in the coronally advanced technique, or you can use kind of like a pinhole technique where you make incisions into the vestibule and put the graft from the apical to coronal, or you can use the coronally advanced flap. But the bottom line is that you have to get this material covered. You cannot leave it exposed because it will not take. So the idea is that then your gingival cells grow into the scaffold and make more new tissue for you. It's like a membrane that we discussed already, but it's much thicker. So here are a couple of cases. Our students have tried this. So you can buy lots of these membranes and you can treat multiple recessions at the same time. When you do that, you can also, if you have multiple recessions or even single recessions, you can use the intraoral scanners to quantify your results if you want to. So that's kind of a part of the tutorial, that if you want to quantify how wonderful your grafting technique was, then you can quantify them by scanning them before and after, and then using your computer to find out how much coverage you actually were able to get. So so this is one of our grad students in the clinic who the axial or dermal. So I hope that these videos will work without kicking me out, but I'm not 100%. I think I want to try, but then I may not be successful. Let's see if I don't push any buttons. So you can kind of see what happens in these areas with the gingival levels. So you go from there and then it kind of grows, and this is after grafting procedure with alloderm, axial or dermal matrix. Another area. So then you can kind of
I think Professor LARJAVA, the connection is not stable right now. I think
Professor LARJAVA, can you hear us?
All right, now I'm back, but now my video is not working. I can't use those videos because it will kick me out every time. For whatever reason, the Zoom is not compatible with my showing any kinds of videos, because it will just kick me out all the way. And now I have been kicked out from the camera as well. So SAIF, do you want me? I need to restart my computer if you want my face. You are mute.
I think we can take the question and move to next session because we are, I think, late. So I think we can take the question from the chairperson. She can ask. I request Professor Zeba to unmute herself and ask some questions.
I'm not finished with my presentation yet.
Yes.
So I still have few slides to show.
Okay. You can say, you can share this. You can share the presentations right now.
Professor LARJAVA, meanwhile you are fixing your system, we can have the chairperson's concluding remarks and the questions from the audience.
All right, so I will restart and you figure out the questions, okay?
Yeah. Meanwhile, Professor Zeba Jaffrey, please, ma'am, your concluding remarks.
Yeah, thank you. Am I audible?
You're audible. You're audible.
Yeah, so good morning, everyone. Myself is Dr. Zeba Jaffrey, Professor at Faculty of Dentistry, Jamia Millia Islamia. It's my honor and pleasure to chair this session where Professor HANNU has talked about soft tissue grafting. Now, I've been listening to him from past 2 days, and I must appreciate his in-depth research on wound healing. This specific session on soft tissue grafting was very well covered, and he's explained the various recession coverage technique, CTG being the gold standard. I'm sure the participant must have had takeaways from the tutorial, which they can incorporate in their clinical practice. I just want to ask Sir, Professor HANNU, that the glue which he has used, does it has any drawback, or is it better than the suture? And does he has any criteria on which technique he uses glue and on which technique he uses suture? And is there any special instrument by which he harvests the connective tissue graft, which causes minimal trauma to the donor site? Maybe. We also have cyanoacrylate glue in India, although I haven't used it myself, but it seemed quite convenient to use glue over suture. But I'm curious to know, is there any drawback of glue over suture?
Do we have Professor LARJAVA?
I think Sir has not listened my query. He's not there, I think.
Ma'am, could you please for 2 minutes? He's just rejoining.
Yes, of course.
Hello, I'm back.
Zeba, please repeat your question. He was not there.
Yeah, Professor HANNU, I was saying that I was appreciating how in-depth research you have done on oral wound healing. And I wanted to ask that the glue which you used for placing the flap or graft, does it has any drawback over suture? Like, do you have the selection criteria that the technique in which you will place the suture and the technique in which you place the graft?
So if I do let's say that I have a 3 millimeter recession where I single tooth pouch technique. So I put the graft in and I leave the collar of the graft exposed. I may coronally position the whole envelope with the graft, and then I apply the tissue glue so it holds the graft with the gingiva and also holds the whole thing attached to the tooth, and no sutures. Some periodontists like using sutures, but I never use sutures if I don't have to. So in some cases, I use additional sutures, like if you have those anterior mandible case where you have a very deep recession where you can actually pull the margins together before you put the connective tissue underneath. You can still do an envelope technique, but you suture your envelope sides together and then you put your graft underneath and then you glue it. So most of the time I don't use any sutures at all, just a tissue glue.
Okay, so you find the healing better with the glue? Better with the glue healing?
My wound healing background gives me the idea that less poking with needles is always beneficial, because every time when you do a suture, you create another wound. So
okay, so minimal trauma.
It will be less trauma. Sometimes what I also do, if I do a suture, so I use non-resorbable, and because if I have a couple of teeth and I have a envelope technique or pouch, So the whole thing moves coronally. So I coronally position my flap, not actually flap, my envelope with the sling suture before I put my graft in, and then I glue.
Okay,
Did
just
you
one more,
follow?
one more question. So any special instrument you use to harvest connective tissue graft, which causes minimal trauma to the palate?
The pallet, I mean, you have to use the, typically the 15C blade, and then the Orban knife, and then I do a periosteal elevator to elevate it all the way from the bone. But for the we have these angled periotomes, and if somebody's interested, I can send information to Dr. Khan, SAIF, what instruments they are.
Send to me, I will share with them.
So
yes,
then,
yes, thank you so much. That will be much
sure.
appreciated.
So it's a blunt instrument compared to the it's angled like Orban knife is. If you know what the angulation for Orban knife is. So it's a similar angulation, but it has a blunt end. So you can create the pouch with that instrument better than with anything else. So it's easy to do. Sometimes we also use, but you don't necessarily have to use them. We use ophthalmic knives that are really, really thin for some cases. But most of the pouches, envelopes, you can do with that angled periotome, and I can send you information about it.
Thank you so much. Thank you, Dr. Saif. Over to you.
Dr. LARJAVA.
Yes.
Dr. Tariq wants to ask some question.
Hello, can you hear me, sir?
Yes.
You can come and ask here.
Dr. LARJAVA, very nice to listen your lectures. It was really very enlightening. My question is, which site, from which side you usually take the graft for? Um,
You mean which side of the palate?
yes.
Well, typically
I'm an
from,
orthodontist, sir.
so I usually take the graft from the same side of the mouth where I will be placing it. So if I place a graft on 1, 3, and 1, 4, I will take it from the opposite side of those teeth. So if I place it in the lower, like if I do a tooth number 3, 3, then I harvest from the 2, 4, 2, 5, 2, 6 area. So trying to keep the wounds on the same side of the mouth so the patient can function on the other side of the mouth, not having wounds everywhere. However, sometimes we do cases where we do multiple grafts and we have to do double harvest. So we have to harvest from both sides of the roof of the mouth. So then obviously wounds are everywhere. And sometimes we do that because the patient wants to do all my grafting at once and I don't want to come back. Kind of a situation. So then we harvest from both sides to get enough tissue. So typically from one harvest, you get about 3 teeth worth of graft.
Thank you so much, sir. Thank you so much.
Sometimes 4 if your teeth are kind of narrow, but typically 3.
Thank you so much, sir, Professor HANNU LARJAVA. Now, moving ahead to our next session, I would like to invite.
Can I do one thing here because I didn't completely finish my presentation, but
he has to do a slight lapse. It was a miscommunication, basically. Yes. Please go on.
So I don't know if there's anything useful. I need to go back.
No. Sure.
So just quickly, let's see
Yeah.
what I had in my mind and see if that will be useful for anybody.
Yes.
So do we have a couple minutes of time
Yes,
still?
yes, you can, please.
Can you see the case?
Yes.
Or the slide? All right, so here's an interesting case from the wound healing perspective anyways. So
Yes.
So we have this 45, 50-year-old male who had advanced recession on the canine and some recessions in other teeth. The patient also had the multiple polyps, and with your orthodontic friend, I want to tell that the patient claimed that these came years and years earlier when the patient has braces in their mouth. Maybe there was some rubbing there, there were fibroepithelial polyps, but they were multiple of them, so I had to take them all out. And then we started with the first grafting case on this in this canine. Let me see if I can get mine. So we had over 8 millimeters of exposed root surface. So when I have a case like that, you will know that you will probably not be able to cover this in one grafting session. So what I did was a double papilla flap. Like I used the tissue on the sides to cover my connective tissue. And then my colleague who works in the same office was in the office a week later and sent me the picture that, you know, the graft looks terrible, what should I do? So I said that, okay, looks like there's a lot of inflammation tissue going on. Maybe there was some bleeding into the site, but do nothing. And let it just heal. And then this is how it healed. So we went from 8 millimeters to about 2-3 millimeters of remaining recession. So then we decided to do a pouch or partial pouch technique. There was a releasing incision and also graft the front tooth in the second procedure. And maybe we still have a 0.5 millimeter exposed, but we went from extreme recession to about 0.5 millimeter exposed. But interesting was the healing response and also the presence of all these fibroepithelial polyps. And that will just be, so I had a few cases here, but I think we cover most of them. So the idea was to ask the audience what they would do in various cases, but maybe we can leave that to the participants to look at the handouts and think about, based on my lecture, what they would do in each of the cases. Like this will be relatively straightforward. You have to look at the aesthetic profile as well of the patient, and that's a completely different lecture to talk about anterior aesthetics. But, you know, single canine, this will be a typical pouch technique with just a tissue cool, no sutures, at least in my hands. Here you have a restoration and a frenum pull. Okay, you can still do the pouch technique. You have to take some of that restoration off and hope that if there's no deep decay, if there's small decay, you have to root plane the root and get rid of the decay and flatten the root surface. You do internal frenectomy, and then you place a nice connective tissue graft underneath and you glue it. But you have to take some of that restoration off because it's covering your CEJ, so otherwise you don't get coverage all the way up. So I will just explain a few of these. So here we have basically no attached gingiva So in a case like this, I probably wouldn't try to put the connective tissue graft because there's too much pull that is difficult to eliminate from the inside. So I will probably do a pre-gingival graft to correct this area to make better tissue. And then a second procedure is, if required, to do a root coverage. So we can place the graft, the pre-gingival graft, to cover most of it. But we know from the studies that the FGGs are not good for root coverage, so it may shrink down, and we may have to do a small connective tissue graft as a second procedure, but it would be difficult to do it once because of the lack of the tissue around the site. That will be still a typical pouch. You have to be careful with the elevation of the tissue because it's so thin, and if you break it in the middle, you are in trouble. Maybe orthodontics should be done first. There's a frenum pool again. The teeth are crowded. It will be difficult to do in this kind of a wide frenum pool without the pre-gingival graft, and then thinking about the other grafts as a second procedure. In this kind of environment, you could do the pouch, or you could do a pedicle flap. So you will use this tissue, nice tissue from the interproximal side, and you suture it with this tissue here. You have to make a fresh wound margin all along so that you can put these two tissues together and the connective tissue graft underneath. Lingual grafting, we don't do it very often. Sometimes patients have tongue piercing, and then it has been rubbing on the tooth inside, and then they have stopped using it, and it's a sensitive tooth. They want to do it. It's more challenging to do because of the large muscle, the tongue that is pushing into the area. So a little bit more technique sensitive. So you may have to do some release on the papillae to get this nicely open, put your connective tissue underneath, and then suture over, and then make sure that the patient will not keep pushing the graft with the tongue, because that pressure may destroy the healing of the graft. All right, I think I have covered enough. So there are lots of cases that you can think about how you would treat them. Remember, single sites like these that are very advanced, double papilla with the connective tissue graft is a good choice. All right, I will come to the end. And now I can thank you very much. This is a view from our house from North Vancouver, and you can see the university buildings over there. So I need to travel. I mean, SAIF knows this because SAIF has been sightseeing in Vancouver. So this goes to a Stanley Park, and I have to go to another bridge, over another bridge, then travel all the way to the Faculty of Dentistry over there. So thank you very much.
Thank you, Professor LARJAVA, for this enlightening lecture. We'll now move to next.
Thank you so much, sir, for such an informative and insightful lecture. Now, moving ahead to our next session, I would like to invite the chairperson for the session, Professor Nishi Tanwar ma'am, from the Department of Periodontia, PGI Rohtak. And as for the speaker, I would like to welcome Dr. SAIF Khan sir, Assistant Professor in the Department of Periodontia, Aligarh Muslim University. The topic for the lecture is chlorhexidine and wound healing.
Good morning to all. As we all know that chlorhexidine is considered gold standard in the antiseptic treatment of oral cavity because of its properties like antimicrobial, plaque inhibitory, and substantivity for at least 12 hours. So we should be familiar with the mechanism of action, indication, and side effects. I welcome our speaker, Dr. SAIF Khan, His lecture will be focusing on chlorhexidine and wound healing. Dr. Saif Khan, please start.
We'll take a 5-minute break before we are set to begin this session.
Sure.
So, am I audible?
Yes, sir, you are audible.
So, I will be talking about the role of chlorhexidine on wound healing, and this is a course about oral wound healing and management of oral wounds. So, chlorhexidine is one of the most commonly used day-to-day anti-plaque agent which we use in dental clinical practice, because dental plaque control is essential, but for any control of dental plaque control is very important as far as the oral wound healing outcomes are concerned. So for that we need either mechanical plaque control measures or chemical plaque control measures. However, mechanical plaque control measures are usually inadequate in their efficacy, so we need some chemical plaque control agents like mouth rinses as an adjunct, but not as a replacement to the mechanical plaque control measures. So chlorhexidine is the most commonly used mouth rinse in clinical practice. So chlorhexidine is a bis-biogenide with central hexamethylene bridge. It is dicotonic, it's positively charged, and has got broad spectrum of activity. And the first study was done by Low and Short, who showed its anti-plaque and anti-gingivitis action. And other studies also supported that it helped in wound healing by reducing the plaque scores and gingival scores. However, chlorhexidine anti-plaque action is due to its strong attraction towards bacterial membrane, leading to increased cell permeability at low concentration and cytolysis and cell death at high concentrations. and it is now considered as the gold standard of all chemical plaque control agents. And the most important thing about its substantivity, it remains or it persists in the mouth for 5 to 8 hours, and it suppresses the bacterial growth for 12 hours. And it makes a reservoir of bacteriostatic milieu in the oral cavity, and basically it decreases all the microbial count. So indications are short-term usage to optimize oral hygiene, or with enhancement of self-performed mechanical measures, or in long-term use is justified of physical, mental, or social handicaps with professional help. So clinical uses are, we all know that it's used as an adjunct to oral hygiene after prophylaxis, as post-surgery, as a plaque control agent, in patient undergoing IMF, in fracture patients or trauma patients, and subjects undergoing orthodontic patient treatment, especially fixed mechanotherapy treatment, which are very tough to maintain. Then mentally and physically challenged subjects, medically compromised subjects, and it can be used as subgingival irrigant also. And there are various vehicles, and concentrate the mouth rinse comes in 0.2% and 0.12%, and other vehicles are also used to deliver the chlorhexidine to the oral tissues. However, it comes with some flip side also. It has got side effects. It causes staining because of the staining is yellow or brown, and it's due to that degradation product, which is parachloroaniline, and protein degeneration, which and formation of metal sulfide, leads to yellow or brown staining. And also there is a Maillard or non-zymatic browning reactions, which is occurring due to condensation of chlorhexidine with carbohydrates, peptides, and proteins, leading to formation of brown substance. Also, it leads to increased suprarenal calculus formation.
तो तू जा रही थी बेटा, तेरा क्या हुआ?
And there is
ऑफिस वाले कह रहे मत जाओ. और
and there is increased supragingival calculus formation, and leads to taste alterations. And also it leads to desquamative and hypersensitive reactions, parotid swellings, and viral infections. And other important thing which occurs associated with chlorhexidine is development of antimicrobial resistance, because dental plaque bacteria are not developing antimicrobial resistance to chlorhexidine. And so the various studies have shown that that chlorhexidine has led to development of antimicrobial resistance. So it's a pressing issue. The over-the-counter uncontrolled use of chlorhexidine is developed. Ignored side effect is the cytotoxic and genotoxic effect of chlorhexidine on oral cells. So oral cells are not immune to chlorhexidine, and the positively charged chlorhexidine attracts bacteria as well as oral cells. So chlorhexidine negatively affects cells in a dose dependent manner. Chlorhexidine, even in lower concentration, is toxic to gingival fibroblasts, epithelial cells, macrophages, neutrophils, and red blood cells in culture. Exposure of human cells in culture to chlorhexidine at concentration equal to or greater than 0.004, that is much lower that we use in clinical practice, causes impaired cellular function and cell death. Also, parachloroaniline is a breakdown product of chlorhexidine, which also causes brown staining, has got mutagenic effects. And low concentration of chlorhexidine inhibits chemotaxis of neutrophils at dose-dependent manner, with total immobility at 0.2% chlorhexidine concentration. We all know that neutrophils are the first line of defense in periodontal tissues. So just we can make out how does using a chlorhexidine can actually deplete the host neutrophils by killing them through cytotoxicity. Also, chlorhexidine reduces changes to human gingival fibroblasts, collagen, and non-collagen proteins. Chlorhexidine reduces gingival fibroblast proliferation in dose-dependent manner and diminish both collagen and non-collagen protein production. Also, chlorhexidine at 0.2% or very low concentration, as a very low concentration on surgical sites for short period of time has toxic effect on gingival fibroblasts and it delayed wound healing. So these studies emphasize that chlorhexidine can totally eliminate the cell proliferation. And chlorhexidine has proven cytotoxic and genotoxic effects evidenced by several in vitro animal and human studies. Our study also we saw that there was increased micronuclei formation. Micronuclei is basically it is a biomarker of genotoxic damage in chlorhexidine users as compared to controls. And another study shows that the chlorhexidine rinsing on healing of oral mucosa and osseous lesions. It shows that there is a delayed and disturbed wound healing in chlorhexidine users as far as oral mucosa and osseous lesions are concerned. And a recent study has shown that chlorhexidine reduces cellular proliferation, increases collagen deposition, and fibrotic marker expression and myofibroblast differentiation. Chlorhexidine reduces expression of RACM1, trigger expression of serpine1 and TMPN, showing scar wound healing response. And also, the chlorhexidine has been used in washing the burned wounds, but it has been shown that it is a potent antiseptic, but it may also induce chemical burns among other side effects. So it's not advisable to infect one patient with chlorhexidine. And now this is the latest systematic review which highlights that the cytotoxicity of chlorhexidine in oral cells and tissues is a complex issue that requires further investigation. While its efficacy in reducing bacterial population and preventing oral infection is well established, and the long-term impact of chlorhexidine on oral health should be considered in the context of its potential cytotoxicity. Practitioners should use chlorhexidine judiciously and be aware of the patient's specific need and risk factors deciding on its use in oral health procedures. So the key takeaways is that chlorhexidine is a gold standard anti-plaque agent and has shown promising results in gingival and periodontal disease. In vitro and in vivo studies show its cytotoxicity and cytotoxic and genotoxic effect on oral cells, epithelial cells, fibroblasts, and neutrophils. A study shows short-term use of chlorhexidine is associated with less cytotoxicity, and chlorhexidine should be used clinically with taking account of risk to benefit ratio. That is, it should be only used for minimal period and not for long-term use, because long-term use, increased duration is associated more genotoxic and cytotoxic effects. So this finishes my presentation. I would be happy to answer any queries from the.
Thank you, Dr. Sam, for delivering such a wonderful lecture, and you elaborated so nicely the use of chlorhexidine and its effect on wound healing. So any question from the audience? So it should be considered that the chemical plaque control or the chlorhexidine, if we use so routinely, it should be used as an adjunct to the mechanical plaque control, not in a routine based. And the studies have shown, you have shown so many studies, research are going on still on the chlorhexidine and its effect on the cell proliferations, especially the fibroblasts. So it should be taken into consideration. So my question for you is, what is the takeaway message for the budding clinician regarding the use of chlorhexidine, especially in the surgical surgeries?
At not more than 2 weeks, if it is required. Otherwise, we should always focus on mechanical measures. It should be the last resort because it is yes, because it is cytotoxic. It is cytotoxic to neutrophils. It is cytotoxic to fibroblasts. It is cytotoxic to epithelial cells. And also the resistance is developing, antimicrobial resistance is developing to chlorhexidine. That's a big, and it is used as an over-the-counter drug. Anybody can use that. So
Exactly.
it should be
Ma'am,
Used
I have
precisely.
one question.
Yes, sure.
Hello,
yes, yes.
Dr. Saif, very nice presentation.
Yes.
I just want after parental surgery, or we can use this chlorhexidine mouthwash for plaque
Yes.
control,
Yes.
because after surgery the tissue is raw. Can we use chlorhexidine mouthwash or
We can
some
use,
other
but for
mouthwash?
no, because chlorhexidine is one of the gold standard mouth rinse. It is all other mouth rinse are compared to it. As far as plaque control is or gingivitis is concerned. So it's the best mouth rinse, but it is a two-edged sword. It comes with
Right.
benefits and it is also destructive also. So we have to use it we have to see the benefit ratio, that whether it is beneficial for or not. We cannot use it as a what you call over the counter, continue it for it. That
No, I just want
use
just after parental surgery, after just
yeah.
parental surgery, we can use this chlorhexidine mouthwash for plaque control, because it
Yes, we
causes
can use
it hamper the healing,
that. Yes,
or
yes,
some
yes.
other mouthwashes.
It is better to use it because it reduces the inflammation, because early healing about inflammation, so it's it reduces the microbial load also, but we should use it for very short time, very short period. We can
Okay.
just after using that we can come on warms and rinses we can use after using using this chlorhexidine mouth rinse.
And
Sure.
moreover,
Thank you
Dr.
so much.
Rajesh,
Thank you so much.
I want to add something, moreover, Dr. Rajesh,
Yes.
regarding the healing
Yes.
process. Studies,
Yes.
the in vitro studies have been suggested some inhibition of fibroblast proliferation
Yes.
in culture, and that is in vitro and animal studies. In the clinical studies, however, it has not been found any interference with the healing process. Rather, better resolution of inflammation is observed just because of the anti-plaque, because bacteria, no infection is there, so healing goes on. But we have to consider the side effects and its limitations.
Right. Thank you so much.
Thank you.
Thank you,
Thank you,
Dr.
Dr. Saif.
Saif, for delivering.
Yes,
Okay,
thank
sir.
you.
Thank you so much. And I also thanks the coordinators, especially Dr. Saif, Andy Gupta, sir, and the organizing team who gave the opportunity to chair the session in GIAN 2025 course. Thank you so much.
Thank you, ma'am.
Thank you so much, sir, for such an insightful and informative lecture. So, good afternoon, everyone. So now we'll be moving for the next session, that is on cytotoxicity of orthodontic appliances on oral mucosa and its implication. The chairman for this session is Professor Sandhya Maheshwari ma'am from the Department of Orthodontics and Dentofacial Orthopedics. Ma'am has an extensive academic and research background with more than 100 publications. She has authored 3 books and multiple international fellowships to her credit. Her expertise and leadership have earned her recognition both nationally and internationally. So we welcome you, ma'am, on board. And the speaker for this session is Dr. ARBAB ANJUM, Assistant Professor in the Department of Orthodontics and Dentofacial Orthopedics. Dr. ARBAB has over 11 years of experience in teaching, and his vast contribution to the field includes numerous high-impact publications in prestigious journals, international collaborations, and leadership roles in the major conferences. So we welcome Dr. ARBAB. So you may start your presentation. Thank you.
Thank you, ma'am, for the nice introduction. Am I audible?
Yes, you are audible.
Thank you. I am Dr. ARBAB ANJUM, Assistant Professor in the Department of Orthodontics at Dr. Ziauddin Ahmed Dental College. Today, I would be speaking on cytotoxicity of orthodontic appliances on oral mucosa and its implications. At the outset, I would like to thank the organizers for giving me this opportunity. I am not able to change the slide. Yes, thank you. I would be covering my topic under these following headings. So, what is cytotoxicity? Cytotoxicity is derived from two words, cyto, which means cell in Greek, and toxicity, which denotes the harmfulness of chemicals, drugs, organisms, or conditions to organisms. In short, cytotoxicity is the quality of being toxic to cells. So, what are the features of toxicity in orthodontics? So, we can divide these factors into a triad: the patient-specific factors, the material-specific factors, and the environmental factors. In the patient-specific factors, we have the patient specificity. By patient specificity, we mean that individual patient response. Individual patients react differently to the same orthodontic force, and the tissue reacts differently. For example, certain individuals, they show hypersensitivity to certain components of the wires, of the brackets. Oral hygiene practices. When we have accumulation of debris, plaque accumulation, calculus accumulation, this leads to bacterial growth and which can exacerbate the cytotoxic process. Assessment of patient age and developmental stage. The pediatric patient, they are more physiologically, the response is different from that of an adult, and the hormonal profile is also different. When we talk about the adaptive response, here we are talking about the tissue's reaction to orthodontic force. So that monitoring is very important. When an orthodontic force is applied, we have to assess the tissue response. Talking about the material specific factors, the orthodontic material composition. For example, the brackets, the wires, the elastics, the modules, all the elements which compose, which are a constituent of this orthodontic material, they can themselves be cytotoxic. The surface characteristics. Let's consider a bracket. A bracket, if it is rough, it is heterogeneous in surface, it can induce tissue trauma and it could be potentially cytotoxic. Corrosion resistance. Corrosion of metals may lead to release of metal ions, which in turn can be potentially cytotoxic. Orthodontic adhesives. Various constituents of orthodontic adhesives have been found to be cytotoxic. Bruma et al. Conducted a study where they compared the self-cure, that is chemical cure, to a light cure composite, and they found that in chemical cure, the amount of unreacted polymer was more, and which was potentially more cytotoxic. Coming on to the environmental factors. Microbial interactions. By microbial interactions, we mean microbial colonization, formation of biofilm, which in turn increases the inflammation and that could be potentially cytotoxic. Saliva. Saliva acts as a medium for the interaction between the brackets and the bacteria. It is also the medium where the corrosive behavior of metals take place and release of metal ions occur. And the last is the duration of exposure. So if a patient is under time orthodontic treatment for a long time, the patient is exposed to potential cytotoxic effects. Moving on to the components which can cause cytotoxicity. So we have metal alloys. We have metal alloys which are present in the orthodontic wires, brackets, elastics, including modules, elastic chains, acrylic components which are present in the removable appliances, adhesives which are used for luting the brackets, the bands, and we have the plastic-based trays, retainers, for example, the clear aligners. Today, I would be talking about the orthodontic wires. So whenever we consider an orthodontic wire, biocompatibility is one of the most important aspect which is assessed. And in this, we talk about the composition and resistance to corrosion. Composition, these brackets have alloys, are alloys, and they have elements like nickel, chromium, cobalt, and which when exposed to saliva, they can release metal ions, which in turn are potentially cytotoxic, and they can trigger cytotoxic responses. Talking about corrosion resistance, Schmalz stated that the oral cavity is an aggressive environment where you have variable pH, temperature, microbial colonization. So all this creates a favorable environment for various types of corrosion, and which can cause corrosion of the metal alloys which are present in the brackets in the wires. So in the choice of a wire, we always consider the composition and the corrosion resistance. Talking about the various wires which are routinely used in orthodontics, we have got stainless steel, which is also known as the 18-8 steel. It has got around 18% of chromium and 8% of nickel. We have got the CrCO alloy alloy, which is around 40% of cobalt and 20% chromium and 15% nickel. Titanium molybdenum alloys, 78% titanium and 11% molybdenum. Nickel titanium, 55% nickel and 45% titanium, and copper nitide, 50% nickel, 43% titanium, and 7% copper. So a study was performed by Tokarzuk, and they did a scanning electron microscope analysis. And what they observed was, what was done was, they observed the wires before and after cellular colonization, and the surface of the orthodontic arch wires were observed. What they found was, this is nickel titanium wire, and what they found was the nickel titanium wire presented a smooth surface, and very few indentations were present. Very few indentations were present in nickel titanium. When stainless steel and titanium molybdenum alloy were assessed, slight surface roughness was seen and heterogeneity with small defects was seen, as we can see here. And when cobalt, chromium, and copper nitide alloys were observed, they found that the surface is very heterogeneous, rough, and similar to an edge surface. Now, further to assess cytotoxicity, cell culture experiments are also done. For that, generally human fibroblasts are taken, but they are expensive, they have a long life cycle, and are difficult to analyze quantitatively. So, mouse fibroblasts are an alternative because they are functionally similar to human fibroblast and they have a smaller life cycle. So a study was performed by Suski et al. And what was done was, arch wires were incubated with fibroblast for 3 weeks. And in the control group, it consists of fibroblast cultures maintained under identical conditions, but without exposure to the examined factors. So one group, we had the arch wire with fibroblast, and the other group, it was just the fibroblast and no arch wire was present. So this was observed under light microscope, and cellular adhesions which were there, which were present, were checked with the help of light microscope. And the cellular nuclei, it was blue. The cell nuclei was blue and cytoplasm was red. So after 21 days of cell seeding, what was found? A confluent cell layer was detected on the following wires: cobalt, chromium, stainless steel, TMA, nitide, and copper nitide. And the special feature of titanium molybdenum alloy was that the cells grew in large round clusters, which was not detectable by other 3 wires. In the case of copper nitide wire, cell growth was also detectable. So what was found was, when the wires were kept with the fibroblast, so they show proliferation. So cell viability is assessed using trypan glue exclusion method and the cell titer glow luminescent cell viability assay. My objective here is just to tell about these assays and what they observe, what they measure. So for example, this cell titer glow luminescent cell viability assay, it assesses the ATPase activity. So it is an indicator of metabolically active cells. So more is the ATPase activity, more metabolically active cells are present. So this is the graph which was produced, and we see this is the control group and this is the tested group, and we see that the cellular viability, the cellular proliferation is more when in the tested group. And here it is less, but it is non-significant. So the cell viability of the mouse fibroblast cells were co-cultured with different wires over a period of 21 days. And their viability was analyzed using cell titer glow assay. The cell viability was increased 1.3-fold in the presence of nitide copper 27-degree wires. So this is that. So what is the crux is that when the wires were capped with fibroblast, there was a proliferation of cells were observed. Next, cytotoxicity was assessed with the help of cytox glow assay. Now, this cytox glow assay works on the estimation of protease level. If the protease level is more, this means that we have more of dead cells. So the number of dead cells is caused by the loss of membrane integrity is calculated using cytox glow assay. And what was observed was the number of dead cells was significantly increased when using almost all the wires, with the exception of copper nitride 27 degree and pure nitride. The increase in cytotoxicity ranged from 1.7-fold and 3.6-fold compared to untreated cells. So we had an increase in cytotoxicity level here in TMA. That was 3.6-fold times. Cobalt chromium, it was 2.7-fold times. Stainless steel, 1.7. Copper nitride, 40 degrees, it was 1.7. So what we understand was that the proliferation was more, and also the cell death was also more. Cellular proliferation was observed and cytotoxicity was also seen. Cell death was also seen. What are the views on cytotoxic action of released metal ions? So Woody et al. Found that nickel chromium alloy was toxic in agar diffusion test and showed no differences compared to those of the control group. Whereas Brantley and Burstein, they found toxic cellular reactions in the form of reduced proliferation of gingival fibroblasts. Cooley et al. Found that generally that the nitride arch wires are not cytotoxic, but their surface microstructures and corrosion resistance can influence cellular responses. Rongo et al., he noted a very interesting thing, that the cytotoxicity of nickel titanium vary over time. The cytotoxicity increases after 30 days, contrasting with the stable biocompatibility of others. Lokai et al. Found good biocompatibility of stainless steel, but they noted that the cytotoxic effect of the soldering alloy attributed it to the release of silver and palladium ions. Mikulewicz, he conducted a study to assess the cell viability and proliferation, and he found steel was the most biocompatible, followed by nickel titanium, followed by titanium. And the ratio of living cells to dead cells, nickel titanium alloy, followed by titanium, and followed by steel. So what is the take-home message? The take-home message is the variety of studies result highlight the complexity of assessing the biocompatibility of orthodontic materials and the need for more research in this particular area. So should we be disappointed that orthodontic treatment is all cytotoxic? And so should we stop doing orthodontic treatment, stop referring orthodontic patients? No, because we have certain limitations with the studies also. The study design they have their own limitations. The limitation of study design, we have difference in alloy composition, surface treatment, and production techniques, which can lead to variation in the surface structure, corrosion resistance, and overall biocompatibility of the wires. These inconsistencies in the manufacturing process results in difference in how various wires interact with the cells, and hence we don't have standardization of results which can be put to a particular group of wires. Next, environmental factors within the oral cavity, such as fluctuation in pH, temperature changes, and the presence of bacterial colonization, they can significantly influence cellular processes. All these studies have been done in vitro. These factors are often difficult to accurately replicate in vitro conditions, which may lead to discrepancies with what we find in the lab and what is the clinical outcome. Last, these studies are based on specific cell lines, different cell types such as fibroblast, osteoblast, and epithelial cells, which may respond differently to the same material. The variability in cellular reactions to orthodontic materials may mean that results obtained from one cell line are not fully applicable to others. So what is the future scope of research? We should have advancement in testing methodologies. Advanced in vitro models should be there that better mimic the oral environment. 3D bioprinted tissue models to create intricate tissue models that closely mimic the oral tissues. Computational modeling and simulation to predict cytotoxicity, and last is the development of biocompatible materials. Nanomaterials with superior corrosion resistance and surface modifications for enhanced biocompatibility. Thank you. Thank you for your patient listening. Any
Thank you
questions?
so much. Yeah.
Thank you, Dr. Wahab, for a very nice
Ma'am.
presentation.
Thank you, ma'am.
You have discussed very nicely the pros and cons of research done to find out the cytotoxicity of orthodontic material. I think addressing the cytotoxicity of the materials in current era is very important, and it should be by multidisciplinary approach between the orthodontist, biotechnologist, material scientist to find out the best orthodontic material so that we have a reduced toxicity as well as good properties of orthodontic material.
Yes, ma'am.
Thank you. Thanks a lot for
Thank
your
you.
nice presentation.
Thank you, ma'am.
Thank you, ma'am, for the concluding remarks. Now, are there any questions from the audience?
Hi, Dr. Neha, can I ask? Hello, am I audible?
Yeah, you're audible.
So, Dr. Arbab, you
Yes, ma'am.
presented about the cytotoxicity. That is very important issue. But most of the results are from the preclinical studies, like in
Right,
vitro
ma'am.
studies.
Yes, ma'am.
So there is a concern
Yeah,
about.
that is yes, ma'am. Can you hear me, ma'am?
Yes,
Hello?
I can. Yes,
Yeah,
yes.
ma'am. So that is the shortcoming of these studies, that most of them are in vitro, and the other part is most of them work on a particular cell line also.
Yeah.
So yes, so that is what we are saying is putting the lab data to the clinical data. The correlation, it is not directly, we cannot put it directly because these studies have to be worked on certain models so that the results which are there are more conclusive.
Yeah, actually, okay, yes, you're right. So there is increase in concern about the increase in allergic type 4 delayed type of hypersensitivity to lot of alloys which are the part of your bands, orthodontic bands and wires, type 4 delayed, and these data are directly from the human studies, observational studies. So and it's very difficult. Like for example, orthodontic treatment subjects are mostly young patients. So once they are sensitized to these orthodontic appliances, so the chances of developing allergy increases over a period of their age. They will be exposed to these materials in future also. So what precautions should be taken either diagnose those like early intervention to diagnose those susceptible
Ma'am,
groups?
yes, ma'am. Yeah, ma'am, the prevalence of orthodontic hypersensitivity, and that is particular to nickel actually, which is reported in the literature, is around 0.3 to 0.5%. And if that is diagnosed, so then we should look for other alternatives, like we can go for ceramic wires, we can go for ceramic braces, and we work on then non-metal alloys. We work on wires which don't have metal, and we work on brackets which don't have metal, but they have their own shortcomings from a biomechanical point of view.
Yeah, I understand. Okay, thank you. It was a good lecture.
Thank you, sir, for the insightful lecture. Let's continue this momentum as we move ahead for the next session. The chairperson for this session is Professor Afshan Bey Ma'am from the Department of Periodontia and Community Dentistry, Sir Ziauddin Ahmed Dental College. Ma'am has an extensive academic and research background with over 100 research papers and multiple international fellowships to her credit. Her expertise and leadership have earned her recognition both nationally and internationally. We welcome you, ma'am. Now I would like to introduce our next speaker, Professor Muhammad Tariq sir, from the Department of Orthodontics and Dentofacial Orthopedics. Sir has over 19 years of experience in academia and clinical practice, specializing in orthodontics. His vast contributions to the field include numerous high-impact generals, international collaborations, and leadership roles in major conferences. We welcome you, sir, for an engaging and insightful lecture on the topic, Plaque Control in Orthodontics, is chlorhexidine our wise choice?
Hello.
Thank you,
Right.
Sumayya. Now, I'm very thankful to Dr. Saif Khan for keeping me as the part of this GIAN conference workshop. So now I would like to invite Professor Tariq for his presentation.
हेलो नीचे हेडफोन वाला आ रहा है एक हेलो एम आई ऑडिबल ये हेडफोन माइक्रोफोन सेट करना है हेलो
Yes, sir, you are audible.
Thank you very much for the nice introduction. Because we have overshooted the our time limit, so I'll be very quickly finishing my presentation. So I'm thankful to the organizers for giving me time to present my slides on this GIAN platform. So the topic given by the organizers is plaque control in orthodontics. Is chlorhexidine a wise choice? So disclaimer, this presentation is only for educational and information purpose. The views presented here are based on my own experience. RCTs and systematic review quoted here are with citations as per intellectual property right. So these are the learning objectives. Plaque control in orthodontics, effect of orthodontic force on periodontium, combined cytotoxicity of chlorhexidine with orthodontic material. Is chlorhexidine a wise choice? Conclusion and take home message. So what we are following in our department, plaque control protocol in orthodontics, there are two protocols, mechanical plaque control and mechanical plaque control with adjunct chlorhexidine oral rinse. First, I will take the mechanical plaque control. Those patients who are maintaining good oral hygiene without braces, with proper education, demonstration, and oral hygiene instructions, these patients are capable to maintain good oral hygiene with braces also, with the help of mechanical plaque control only. So the patients who are coming to OPD and they are having good oral hygiene, so if we teach them properly, we demonstrate them how to clean the teeth, they are capable to maintain the plaque control by brushing, flossing, and interdental toothbrushes, like that. Mechanical plaque control with the adjunct chlorhexidine oral rinse. Those patients with poor oral hygiene without braces, Such patients require oral prophylaxis followed by comprehensive oral hygiene instructions. These are the patients who require chemical plaque control as an adjunct to mechanical plaque control. So after oral prophylaxis, maintenance phase of 1 month before starting orthodontic treatment is necessary for these patients. One more important thing is orthodontic force. Orthodontic force causes trauma to the tissues. Injury, lack of blood supply, and lack of oxygen supply and nutrient supply that leads to tissue damage that initiates inflammatory cascade. I will not go into detail because for the last 2 days we have already covered or we have listened all these things regarding inflammation. So orthodontic force are 2 types. We can use light orthodontic force. When we are using light orthodontic force, means if the force is optimum and patient is able to maintain good oral hygiene, then tissue responds very well to these types of forces. Controlled tooth movement is achieved, and only subclinical gingival inflammation is present with light orthodontic force if patient is able to maintain good oral hygiene. Subclinical gingival inflammation means we don't see bleeding on probing clinically. On the other hand, if we use heavy orthodontic force, the effect on periodontium is very bad. There is increased inflammation, excessive bone resorption, attachment loss, root resorption, gingival recession, and tooth might get mobile. Now, the cytotoxicity and genotoxicity of chlorhexidine and orthodontic biomaterials. We have listened to previous lectures, one by Dr. Saif Khan and the other by Dr. ARBAB ANJUM. They have covered these 2 things, and by listening them, so we know that chlorhexidine is cytotoxic and orthodontic biomaterials are also cytotoxic and genotoxic. So whether we should use chlorhexidine or whether we should use orthodontic biomaterials in our patients, because they are they are having potential of causing cytotoxicity and genotoxicity. So the combined effect of toxicity of the chlorhexidine with orthodontic materials together, they have additive effect on cytotoxicity and genotoxicity. Means if the patient is using chlorhexidine only without braces, then it is causing cytotoxicity and genotoxicity. And if the orthodontic patient who is having biomaterials in his mouth like braces, wires, elastic, etc., so these materials are also causing cytotoxicity and genotoxicity to the oral mucosa. More chromium and nickel leach out in patients using chlorhexidine mouthwash and causing more oxidative stress, more damage to cell membrane, DNA, proteins, and organelles. I will not go into detail because these points already have been covered by Dr. ARBAB ANJUM. So if we see the randomized control trial or systematic reviews, the literature, all these systematic reviews and randomized control trials, they conclude that removal of orthodontic appliances and discontinuation of chlorhexidine mouthwash both will lead to reversal of localized genotoxic and cytotoxic effect. So as soon as we debond the orthodontic biomaterials, the cytotoxicity and genotoxicity, we see the reversal of this effect. Because cells are capable to repair the damage done. So cells are capable to repair its DNA, they are capable to repair their protein, cells are capable of repairing their membrane also, and they are also having antioxidant defense system And this defense system can neutralize the harmful free radicals also. So the question is chlorhexidine a wise choice? Let's see. Because the damage done is not severe, cell can start repairing the damage as soon as patient stops using chlorhexidine. Patient's immunity is capable to reverse the toxic changes gradually. The damaged cells are replaced by a new cell generated through cell division. So my conclusion is chlorhexidine mouth rinse should be used sensibly and only in cases of active gingival inflammation, considering risk to benefit ratio and for short period of time. Active gingival inflammation means the patient is having gingivitis and clinically there is bleeding on probing. So in such cases, patient might need chemical plaque control also, but we should use for short period of time, because studies are there that show the longer we use the chlorhexidine, the damage done is more. So the take home message is maintain your oral hygiene by brushing after every meal. This is very important, especially for the orthodontic patient, because the braces the food material is thick, and if patient is unable to clean them at that time, then they stick to them and it will be very difficult to remove them after some time. So professional cleaning will be required for that. If the patient don't have the brush, if he's outside, he's having some food, so at least he should gargle with plain water so that most of the food material he can spit it out. The second take home message is strengthen your immune system by eating nutritious food. We should include fruits, vegetables, dairy product, meat, whole grains, nuts and seeds in our diet, exercising and getting enough sleep. Thank you very much.
Thank you, sir, for the insightful lecture. Any questions from the audience are invited. I would like to call chairperson for the session for the concluding remarks.
Dr. Tariq, it was a very good presentation, I think, and it was very elaborate. You have elaborated nicely. Whatever you have said, that we should use chlorhexidine as a mouthwash, it depends all upon the concentration and the duration, how you use. So definitely it causes changes in the cells which are present on superficially, which are present in the oral cavity. So I think it was a very nice presentation, and hope everyone will get benefit from this presentation. Any questions are invited from the audience?
Thank you, Dr. Afsha. Myself, Dr. R.K. Tiwari. I don't have any question, but there are few things I just want to know. There are 3 consecutive presentations by Dr. SAIF, by ARBAB ANJUM, and by Dr. Tariq. The matter which was related to pharmacovigilance. We had a lecture on pharmacovigilance in dental college. These things comes under the pharmacovigilance. Is any record is been prepared in the department? If not, it is my suggestion that such cases like where there is irritation or non-anemic ulcer due to medicines or due to trauma of orthodontic appliance, they should be recorded. Cytotoxic, the cytological effects and the microscopic studies may be done at higher level when we select a student for these studies. But for pharmacovigilance purposes, such things should be recorded in the department. This is my view. Thank you very much.
Yes, sir. Yeah, thank you, sir.
Thank
Your
you, sir.
views, good views, and I think we should keep a record for these studies. These type of it goes under research, and it will take, I think, years to get the results. I think we should do this in the department. Thank you, doctor. Thank you, everyone, and thank you, Dr. SAF team.
Thank you all. I think it was the last presentation. So still 38 participants are there. I thank to all of them.
So this comes to the conclusion of day 3. So tomorrow we'll be meeting at 8:30 with the Professor HANNU LARJAVA's periodontal regeneration, then second on the healing and maintenance on implants. And then we're going to have two very interesting sessions. First will be of ortho-perio-synergy by Professor N.D. Gupta and Professor Neha. And second will be of perio-endo-lesions, strategies for better healing outcome come by Professor Vivek Sharma and Dr. Shariq Alam. And these two sessions will be very scintillating and very exciting. I request you please join us tomorrow at 8:30. Till then, I take your leave.
Please give the link for attendance also.
Okay, Dr. LARJAVA. I left. Uncut.